The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Okay, so welcome back to our next set of topics. No? So next natin ay yung autonomic nervous system. So for the autonomics, actually it's one of the major topics that you have to know by heart talaga, no? Kasi it encompasses a lot of topics sa buong pharmacology, no? Madaming na itatanong na autonomic drugs kahit na hindi ka under this set of topics, no? Pwede siya sa diabetes, pwede siya sa cardio and all, no? So ayan. So what I want you to do here, no, is for us to be able to compartmentalize muna yung dalawang big set of systems natin, yung ating sympathetic nervous system and the parasympathetic nervous system. Okay? So tapos i-discuss natin sa sympathetic nervous system ano yung agonist and mga antagonist. Okay? Sa parasympathetic, ganun din. Agonist and yung mga antagonist. So, ganun natin siya i-memorize, no? Or i-put into mind. Okay? So, just a quick ANS anatomy, no? I want you to remember this picture para mas madali, no? So, mukhang bulate pala to, no? But this is the brain, no? Ayan. That's your brain and your spinal cord, no? I want you to draw it this way kasi parang mas visual ko siya nakikita. Draw a long line dyan, parang rainbow. Then draw this one. And ganyan. Again, in sequence kung paano ko siya drino, ganun yung siya i-draw. Okay? And then draw a small line here with a long one. Okay. Okay? So, between P and S, di ba, mauuna sa alphabet si letter P. So, write letter P on top and letter S below, no? This signifies the parasympathetic nervous system and the sympathetic nervous system. At dahil drawing nyo siya sa taas, no? Si parasympathetic nervous system involves your craniosacral, meaning yung cranial nervous system, ay, dito sa part, no? Cranial nervous system natin and the sacral, okay, nervous part of the whole spine, no? Okay. So next, sympathetic nervous system, ito naman, it involves the thoracolumbar section. Okay, this one, craniosacral section, and the thoracolumbar section is for sympathetic. Kaya siya nandun, kaya ganyan yung drawing niya. Thoracolumbar nasa may gitnang area, okay, ng body dito. Okay? And then dito sa may taas, no, ang main so from the central nervous system, from the central nervous system, no, which is yung yellow na brain and spinal cord dyan, okay? Ang nare-release na neurotransmitter dyan is your acetylcholine, okay? Acetylcholine. So acetylcholine yung lumalabas from your dun sa central, no? Papunta dun sa ating mga two types of nervous system, no? So your ACH is primarily the preganglionic neurotransmitter in both, no, sympathetic and parasympathetic nervous system. Nasaan yung ganglion nyo dyan? Okay, kulayan ko ng green. Okay, the green are the ganglions which are made up of clusters of neurons, no, kaya sa labilog na nandyan, no? So, yun yung parang visual representation niya. Okay, so lahat ng before the ganglion, okay, lahat ng before the ganglion ay pre-ganglionic nerves, no? And yung after nung ganglion are your post-ganglionic nervous post-ganglionic na section ng ating sympathetic or parasympathetic nervous system. So pag tinanong kayo ano yung neurotransmitter na primarily seen in the parasympathetic and sympathetic nervous system pre-ganglionic, no? It's your ACH. Once you, okay, reach, kunwari yung ACH, no? Your ACH will be released dito sa synaptic cleft natin, no? It will meet different receptors. Okay? Sa parasympathetic nervous system, it will meet your nicotinic neural receptors, no? Nicotinic neural receptors. Okay? Same with this one. Okay? But it will really, in parasympathetic, it will release your ACH. No? ACH. Dito, ang postganglionic neurotransmitter na na-release once na-activate si nicotinic neural ay sino? Tawag dito? Dopamine, no? Dopamine, epinephrine, and norepinephrine. Naintindihan ba? And, okay, dito sa ating parasympathetic nervous system, si ACH, mamimit niya dyan yung receptors niya. Okay? Mamimit niya dyan yung receptors niya, si nicotinic, muscular, and si muscarinic receptors. Okay? This is your at the organ level. Okay? At the organ level. Mapa mata man yan, mapa lungs man yan, okay? Or kung saang areas of the body, the uterus, mga ganyan. Okay? So next, sa sympathetic nervous system, okay? It will meet the receptors known as your alpha, beta, and your dopamine. Okay? So yan yung basic anatomy of your sympathetic or autonomic nervous system. Malinaw ba iyon? So, kapag tinanong kayo ngayon kung sino yung long, short, no? Short postganglionic fiber, yan din yung picture na yon, no? Kung makikita nyo yung kung tinanong kayo, ano yung length nung parasympathetic fiber na preganglionic? It's long, 'di ba? Makita nyo kasi nag-drawing kayo ng long. Tapos short yung postganglionic fiber niya. Pero kung tinanong kayo, saan mas malapit yung ganglion ng sympathetic nervous system? Makita nyo rin sa picture na to. Mas malapit siya sa CNS or dun sa central nervous system. Malayo siya sa organ. Ang malapit sa organ ay yung nasa parasympathetic nervous system. So this whole picture will summarize everything nung buong ANS anatomy natin, and make sure that you memorize this by heart. Again, daanan natin paglabas nung sa brain and spinal column, no? Ano yung preganglionic neurotransmitters natin? ACH. ACH will have to meet yung receptor sa ganglion? Nicotinic neural. Pag na-stimulate yon, dun sila magkakaiba. Si parasympathetic, ACH yung postganglionic neurotransmitter niya, while in the sympathetic, ang neurotransmitter niya ay si dopamine, epinephrine, norepinephrine. Maliwanag ba yon? So that's your whole ANS quick anatomy. So daanan lang natin yung mga different organs in the body, no? So, in your eyes, no? So, in your eyes, makikita natin may radial muscles tayo, no? Yung radial muscles, ibig sabihin yan yung mga pagganito. Ito. Ang hirap i-drawing. Basta yung paikot. Kunwari yan. Sila yung mga muscles na palabas. Kaya siya tinawag na radial, no? Radial muscles. While your circular sphincter muscles, ito yung light blue-green, no? Ito, yung mga light blue-green na ganito. Ito yung radial. Okay? That's the radial. Yung radial smooth muscles natin, no? Yung radial smooth muscles natin are primarily innervated, have receptors known as your alpha-1 receptors. While your circular muscles will have your M3 receptors. Okay? Circular, M3, radial ay alpha-1 receptor. Ngayon, yung M3, so ngayon isipin natin, pag parasympathetic, di ba ang parasympathetic nervous system natin, it involves what receptors? Primarily, nicotinic and muscarinic. Tandaan natin yun, ha? So, sympathetic, ano yung mga receptors dito? Di ba? Alpha, beta, and dopamine. Okay? So ngayon, tignan natin. Parasympathetic, muscarinic receptor, saan yun makikita sa eye? Radial or sa circular? Sa circular. Ngayon, pag in-stimulate mo daw si M3, di ba? Anong mangyayari? Anong itsura ng radial muscle, ay yung circular muscle mo? Paikot. Pag in-stimulate mo si radial muscle, magko-constrict yan. Kaya sa parasympathetic, ano nangyari sa mata? Nagkaka-meiosis or lumiliit yung pupil. Pero kapag in-stimulate mo ay alpha-1 receptors, ano nga ang alpha-1? Sympathetic, parasympathetic? Sympathetic, no? Pag in-stimulate mo siya, magko-contract yung ating radial muscle. Ano nangyayari pag nagko-contract? nagkakaroon ka ng mydriasis. Maliwanag ba iyon? So mydriasis is sympathetic in effect kasi it involves what receptor? Alpha. Si meiosis or constriction, no, is a para or sympa? Parasympathetic, and it involves what receptor? M3 receptor. Maliwanag ba iyon? So yun yung doon sa ating eyes. Okay? Next will be your ciliary muscles, no? Your ciliary, ay, nawala yung aking iPad. Okay? Your ciliary muscle will involve beta receptors, no? Your beta receptors and also your muscarinic receptors. Yung ciliary muscle natin, again, sabi natin, beta receptors and muscarinic receptor. Yung ciliary muscle mo ay ito, no? Ano daw yung content na receptor niya? May beta receptor siya and may muscarinic receptor din siya. Beta receptor, okay? Yung beta receptor, what it does is, okay, ang gagawin niya will be bakit nawawala? Sorry, nagkaka-technical glitch. Okay, so yung beta receptors natin, it will cause relaxation. Okay, relaxation of your muscles, while your muscarinic receptor will cause constriction. Okay? Constriction. Okay? So ngayon, yung ating beta receptor, pagka in-stimulate mo daw siya, okay, nagre-relax yung ciliary body. And ang orientation kasi ng muscle mo ay pag ganito, yung fiber niya. Ano ba ito? Lakihan ko ha. So ganyan. Ganyan. So ito siya. Okay, yan. So nakapaganyan. So pag nag-relax siya, mas humahaba siya. 'Di ba? Mas humahaba siya. Kasi nag-relax siya eh, no? So ngayon, pag nag-relax siya, itong mga suspensory ligaments mo, yan, suspensory ligaments mo, na nakakabit dyan, dahil humaba siya, numinipis siya, nahihila niya yung suspensory ligaments. Na-imagine niyo ba? So dahil nahila niya yung suspensory ligaments, ang nangyayari ay nahihila niya yung lens. Okay? So nahihila niya yung lens, no? Mas nakakakita ka ngayon doon sa malayo, no? Farther distances. So dahil lumipis at lumiit yung lens. So kailangan mo 'yon, no? During your sympathetic nervous system activation, no? Ngayon, dun naman sa other side, ano daw yung pampa-constrict ng ciliary muscle mo? It's your muscarinic receptor, di ba? Your muscarinic receptor, pag nag-constrict si ciliary muscle, ano mangyayari kay muscle? Iikli or hahaba? Iikli. So, lumiit siya ngayon. Magiging lang siyang ganito. Siyempre, pag maikli siya, para siyang tumaba, di ba? So, ngayon, dahil tumaba siya, yung mga suspensory ligaments na nakalagay dito, nag-loosen up, di ba? Dahil nag-loosen up siya, yung lens mo maglo-loosen up din siya. So kakapal siya. So therefore, the gaze will now, okay, shift to a nearer subject, no? Ito yung tinatawag na accommodation, no? Pag mas malapit, di ba? Pag nilapit mo ganyan, no? Ma-feel mo na mag-a-adjust yung eyes mo ng onte, no? Because the ciliary muscle should constrict, therefore yung suspensory ligaments natin should be loosened. Okay? So ano nangyari? Pag closer distance na vision, yung parasympathetic nervous system natin yung na-activate for you to see yung object at a closer level. Okay? So yon. So next, receptors naman sa heart. So, syempre, yung mga receptors natin sa heart, meron din namang beta receptor. Primarily involve your beta receptors. Pero ano lang ba nakikita dyan? Beta 1 receptors lang ba? Hindi, no? Both beta 1 and beta 2 are seen in the heart. However, beta 1 is the primary receptor seen in your heart, no? More than your beta 2. Pero, meron bang parasympathetic nervous system receptors dito? Okay, so this is the sympathetic. Meron bang parasympathetic? Yes, your M2 receptors. Your M2 receptors naman, they are also found in your heart and will cause bradycardia. Okay, papabagalin niya. Dito sa sympathetic nervous system, tachy, no? Remember, sympathetic, fight and fight or flight, di ba? Reaction. So, syempre, kailangan mabilis yung heart mo. Yung isa naman, rest and digest, kaya bradycardia. And it involves your M2 receptors. Okay, next, your blood vessels naman. Your blood vessels, you have your, meron tayong may mga blood vessels kasi tayo sa skin and the splanchnic area. Splanchnic yung dito sa tiyan natin, no? They are primarily innervated by your alpha receptors, no? Alpha receptors, primarily alpha 1 more than the alpha 2 receptors. So mas madaming alpha 1. So para inyong matandaan na mas madali, no? Pag rinowin niyo yung alpha 1, mukha siyang blood vessel, no? So, therefore, your alpha receptors are mostly seen in your blood vessels. And anong ginagawa ng alpha 1 pag na-stimulate niya? It constricts. Okay? It constricts the blood vessels. Okay? It constricts your blood vessels. Pero, okay, meron din tayong mga vessels na papunta sa skeletal muscles, no? Kung kanina, mga smooth muscles papunta dun sa skin and splanchnic area, pagka blood vessels papunta sa skeletal muscles, no? Skeletal muscles, ang receptor niyan is primarily innervated by your beta 2 receptors, okay? Beta 2 receptors, okay? Kapag in-stimulate mo si beta 2 receptor, no? Contrary dun sa alam natin na vasoconstriction pagka sympathetic nervous system, nagko-cause siya ngayon ng vasodilation. Okay? It causes vasodilation compared to yung alpha receptors natin. Okay? Okay, so now let's go to the receptors of your GI tract. So for your GI tract, ang gawin natin dyan, mag-drawing tayo ng intestine muna and a sphincter. No? A sphincter. Okay? So, tignan muna natin. Pag parasympathetic nervous system, di ba rest and digest tayo. Gusto natin mag-peristalsis, makadigest ka, mag-move yung bowels mo, no? Hence, okay, ang receptor, ang gusto natin dito, no? Meron kang muscarinic receptor sa walls ng intestine, meron ka ring muscarinic receptors doon sa sphincter. Okay? So, pag parasympathetic, pag in-stimulate mo si M3 na nasa wall, ang gagawin niya ay, constrict. Kasi gusto mong pigain, gusto mong mag-cause ng peristalsis. So, it constricts, di ba? Now, if you stimulate the M3 receptor on the sphincter, ano nangyayari? It should dilate. Kasi kailangan niyang padaanin yung ating food or yung substance na nandun sa loob. So kasi you are resting and you are digesting. Okay? Tandaan, iba ang function niya kung nasa wall siya, iba ang function niya pag nasa sphincter siya. Okay? Next, sympathetic nervous system. Pag sympathetic nervous system, ang involved na receptors dito ay alpha 2 and your beta 2. And sa sphincters, kapag sa wall alpha 2 and beta 2. Kapag sa sphincters, it's your alpha 1. Okay? Receptor. Tandaan natin, sympathetic nervous system is fight or flight, di ba? Siyempre pag nakikipag-away ka or fight or flight, ayaw mo that you'll have pupu, di ba? So kailangan focus ka dun sa ano. So anong nangyayari doon? Hindi gumagalaw yung laman ng tiyan mo. So hence, para mas madali nyo siya maalala, no? Ayaw mong pagalawin yung food sa tiyan mo, no? Hence, yung alpha 2 and beta 2 stimulation will cause relaxation. Okay? Relaxation. Hindi sila gagalaw. Steady lang silang ganyan. While your alpha 1 will cause constriction. Okay? Ibig sabihin, close yung sphincter, relax yung walls, hindi gagalaw yung bowels. Okay? Yun yung concept behind this GI receptors. Okay? And also guys, I'll take this opportunity na rin, no? Sa sympathetic nervous system, usually pag nakita niyo si alpha 2 and beta 2, mas relaxation yan. Yung number na 2. Okay? Number 2 is to relax. Okay? So next. Okay, so next we'll be discussing the genitourinary system, no? And the reproductive system then as well. So kapag ka sinabi nating parasympathetic and sympathetic in terms of urination, no? Dito sa parasympathetic, you want to urinate. Okay, you want to urinate. Dito, no urination. Okay, no urine. So, pag parasympathetic, ang receptor mo dyan would be M3, no? Your M3 can be seen dito sa detrusor muscle natin. and it can also be seen dun sa bladder neck natin. Pero iba yung reaction niya, no? In terms of the location. Pag M3 na stimulate siya sa bladder wall, no? Imagine natin anong goal ng parasympathetic? To urinate. So therefore, yung detrusor muscle would what? Constrict or relax para makaihi? Constrict, no? It should constrict or contract, no? While the bladder neck should, para makaihi, it would relax or constrict. It should relax, no? So dito, it should relax. All right? So, ngayon naman, punta tayo, yun yung parasympathetic innervation ng ating urinary system. Now, kapag sympathetic innervation naman, no? Ang gusto natin, ayaw mong makaihi. So, ang gusto mong gawin, i-constrict mo si neck, di ba? And ang nagko-constrict ng bladder neck ay alpha-1 receptor. Alpha-1 receptor. Okay? While your bladder wall should what? Relax or contract? Relax para hindi ma-push yung ihi palabas, di ba? And that is innervated by your beta-2 receptor. Okay? So para hindi ka makawiwi. Next, doon naman sa uterus, meron ka rin dyan lining, meron ka rin mga beta-2 receptors. And when you, okay, stimulate your beta-2 receptors, no, it will cause relaxation. Okay? Kaya tandaan natin, guys, na pag may baby dito sa ating womb, no, pag gusto mo siyang pakapitin, magbibigay ka ng relaxant. Ayaw mo mag-contract yung uterus or else lalabas si baby, no? So ayaw mo mag-contract si uterus. So you give your so-called tocolytics. Okay? Your beta-2 receptors are tocolytics. Maliwanag ba iyon? Okay, next we have the following organs naman. So in your kidneys, you also have your beta-1 receptor. When you stimulate your beta-1 receptor, particularly in fight or flight reactions, no, you increase the release of your renin. And increasing the release of renin will activate yung RAAS system natin, increasing the blood pressure, no? Kaya nakita mo usually increased blood pressure in fight or flight responses. Next naman, in your liver, you have your beta-2 receptors. This is also involved in your glycogenolysis and gluconeogenesis. No? Tandaan natin, in fight or flight reaction, kailangan mo na madaming energy. No? Kailangan mo makuha or ma-reap lahat ng energy from other different sources. No? Kaya kailangan mo ma-stimulate yung gluconeogenesis and glycogenolysis, no? By the beta-2 receptors. Okay, beta-2 receptors. Okay, so now that's all for the basic autonomic system, no? Autonomic nervous system. We now go to the cholinergic pharmacology. So cholinergic nervous system muna tayo, okay? But before that, take a break, try to analyze, try to study muna ulit yung mga dinaanan natin kanina, and then when you're ready, get back to cholinergic pharmacology. Okay, see you in 5 minutes. Okay, so next, start na tayo sa ating cholinergic pharma, no? So to start, no, we have to know how acetylcholine is formed, no? Kasi acetylcholine is the main neurotransmitter that is used in your cholinergic nervous system. Kaya nga tinawag siyang cholinergic kasi acetylcholine, no? So choline, no, enters your presynaptic neuron, no, through a receptor, no, and that's inhibited by the inhibitor hemicholinum. Ngayon, pag pumasok ngayon si dito tayo. Pag pumasok ngayon si choline now is combined with your acetyl-CoA, with your choline acetyltransferase, no, forming your acetylcholine. Ngayon si acetylcholine, guys, no, tandaan niyo na madali yan ma-degrade, no? So you have to put it inside a vesicle, no? Para hindi siya agad masira. Now, that transportation, no, from the presynaptic neuron to the vesicle, no, is inhibited by your vesamicol. So again, hemicholinum yung entry, no, vesamicol yung pagpasok sa transporter, no, and when you need your acetylcholine, no, in the peripheral, no, kailangan mo siya ma-release, no, your vesicle should mix with the lipid membrane of the synaptic neuron, and then your acetylcholine is released to the cleft, that's the synaptic cleft. Now, mainly your acetylcholine, it can have 3 fates, no? Your acetylcholine can bind to the cholinereceptor. Ano yung mga cholinereceptors natin na na-discuss kanina? It's your, di ba? Nicotinic and muscarinic receptors, di ba? Or, no, it can be degraded to choline and acetate using your acetylcholinesterase. Okay? Acetylcholinesterase. Or it can also be, okay, reabsorbed back or transported back to the synaptic cleft, to the presynaptic neuron para ma-recycle siya. So those are the three fates of your acetylcholine. Okay? So, important dyan to know itong mga inhibitors nila. Si hemicolinium, okay? Hemicolinium, yung pag-enter. Vesamicol for the transporter, and pag-attach nung ating vesicle to the membrane of the presynaptic neuron by botulinum. Okay? So, those are your inhibitors. So, next, in your cholinergic nervous system, there are two main receptors. Tandaan natin yung nicotinic receptors and your muscarinic receptors. If we recall yung drawing natin kanina, you recall this brain, di ba? Tapos sabi ko, saan nga yung parasympathetic? It's yung pinakamataas, ay yung taas na portion na drawing natin, di ba? And sabi natin kanina, acetylcholine is the main neurotransmitter in the preganglionic, di ba? And in the postganglionic, what's the neurotransmitter again? It's your acetylcholine, di ba? And kanina, diniscuss natin na merong nicotinic receptor dyan, particularly nicotinic neural. And doon sa end organ natin, meron din tayong nicotinic pero muscular naman, no? And yung isang receptor ay muscarinic receptor. Hence, itong dalawa ngayon yung ating mga receptors in your parasympathetic nervous system. Naiintindihan ba? Okay, sige. So, your muscarinic receptors, no, particularly your M1 receptors, no, isa-isahin lang natin, no, M1, M2, M3. Yun yung pinakakadalasan na kilalang mga receptors. Kanina, 'di ba, nabanggit natin yung M3 receptors, 'di ba, doon sa GI tract natin, no? Kasi pinakamadami din siya along in the body, no? Your M1, no? M1 is seen primarily in your nerves, no? While your M2, saan nyo narinig kanina yung M2? In your heart, no? And what does it do? It causes bradycardia. It causes bradycardia, correct. And your M3 receptors naman, it's seen in your exocrine glands, no? Yung mga exocrine glands natin and the different organs that were mentioned a while ago. Next, your nicotinic receptors, sabi natin, 'di ba? Meron tayong nicotinic neural and nicotinic muscular. Okay? Nicotinic neural, saan makikita? Sa ganglion. Nicotinic muscular, doon sa organ itself. Okay? So again, muscarinic, 1, 2, 3. 1 is nerves, 2 is heart, no? 3 is exocrine glands. Okay? So yan yung mga different receptors natin under cholinergic nervous system. Now, let's start first with your cholinergic nervous system. No, pag pag sinabing agonist, no, syempre yan yung mga enzymes or mga drugs na nagko-cause ng activation ng cholinergic nervous system natin, no? Sila yung tinatawag ding cholinomimetic, no? Bakit siya tinawag na cholinomimetics? Kasi choline, no, means acetylcholine, no? While mimetic means similar to, no? So it's like acetylcholine-like, parang ganun, okay? It mimics the action of your acetylcholine. Kaya again, ang tawag sa kanila ay mga mimetics. Okay? Mga cholinomimetics. Okay? So these are your cholinergic agonists. So kapag ka cholinomimetics, no? Tandaan natin yung acetylcholine, di ba? Most of the actions of your cholinergic agonist will revolve around yung tinatawag nating dumbbells, no? Yung dumbbells, yung diarrhea, diaphoresis, no, abdominal cramps kasi peristalsis, may dumbbells U for urination, no? M for meiosis, 'di ba? If you recall kanina, doon sa ating saan ngayon circular muscle ng eyes, 'di ba? It will cause constriction causing meiosis, no? Bradycardia, yung M2 natin. Tapos emesis, lacrimation, and lethargy, no, and salivation. Pagka cholinergic nervous system, parang matubig, masyadong basa, no, mabagal, rest and digest. Yun yung imagine niyo sa mga effects ng cholinergic drugs natin, no. Yun kasing effect ng ating acetylcholine. Okay? So next we have to discuss is ano ngayon yung mga direct acting and indirect acting agonist natin. Pag sinabing direct acting, again, siya ay nag-a-act sa receptor. Ano nga ulit yung receptors ng cholinergic nervous system? Your nicotinic and muscarinic receptors. Pag sinabing indirect acting, ang ina-act upon niya ay si acetylcholine esterase. If you recall yung picture kanina, dun sa baba, di ba, fate ng acetylcholine ay ma-degrade, di ba? Ng acetylcholine, di ba? To choline and yung acetyl-CoA natin, di ba? Para wala na siyang function, di ba? So ngayon, if you degrade this acetylcholine esterase, anong mangyayari sa levels ng acetylcholine? Tataas, bababa? Tataas. Kasi wala kang nagde-degrade sa kanya. So that's how it enhances yung cholinergic effect niya. Yung isa, direct acting, magbabind siya dun sa receptor para mag-cause ng action. Okay? Yun yung difference nilang dalawa. Let's start first with your direct acting. Pag sinabing direct acting ng acetylcholine receptors, no? Pwede siyang non-selective, muscarinic selective, or nicotinic selective. Pag non-selective, either muscarinic receptor, kahit muscarinic yan, nicotinic yan, ay papatusin niya. Okay? So ang mangyayari dyan, it stimulates these two receptors. And the prototype has that capacity. And ang prototype natin ay sino? Si acetylcholine. Okay? Ang use dati ng acetylcholine ay for pang-constrict nung ice natin, pero mas hindi siya ginagamit talaga as a drug, no, clinically. Next, puntahan natin yung mga muscarinic selective, no. You have your betanicol, pilocarpine, carbachol, and cevimeline. If you can see, no, lahat ng mga substances na related sa acetylcholine, they have col in their name. So if narinig niyo yung call sa pangalan, no? Likely it's an agonist, no? Kamukha niya si acetylcholine. It's a cholinergic agonist, no? And your betanicol, it's used for bladder and bowel atony, no? Ginagamit si B for bladder and bowel atony. Ayan, atony meaning hindi ka nakakaihi. Pero ang gusto mong gawin, papaihiin mo siya. No? If you recall, di ba anong receptors yung nandun sa GU natin kanina? It's your M3 receptor. And if you stimulate your M3 receptor dun sa detrusor muscle, ang gagawin niya, it will contract the detrusor muscle, it will relax the sphincter, causing the patient to wee-wee. Di ba? Isa tong drug na ginamit ko recently lang, actually 2 days ago lang, para sa bladder training, no? Kasi matagal na naka-Foley cath yung patient ko, and ang ginawa ang nangyari, kailangan mo siyang ma-train back na makaihi siya, no? So kasi pag inalis mo yung Foley cath after a long time, no? Ang mangyayari ay hindi niya kayang umihi dahil nagde-depend siya dun sa Foley eh. So ngayon, you have to train the bladder na mag-contract, no? Pagka puno na siya. So you give betanicol for that, okay? Bladder and bowel atony. While your carbachol naman, it can also be used for the same, okay, for the same function, pero mas ginagamit yung betanicol talaga. So other drugs under your muscarinic, you have your pilocarpine and your cevimeline, okay, your cevimeline. Okay, other use ng ating mga muscarinic acting agents would be for the Sjogren syndrome na tinatawag, okay? Anong spelling nun? It's your Sjogren syndrome, okay? Yung Sjogren syndrome, usually ang nangyayari dito is you're dry everywhere, no? Dry yung eyes, dry yung mouth, no? And what you do is you increase the amount of secretion by giving these direct acting muscarinic agonists. Okay? Maliwanag ba 'yon? So those are for your muscarinic agonist. Now, pag nasobrahan ka ng muscarinic agonist, no, these are the side effects, no. Remember the mnemonic, I'm covered in sludge, no. Sludge for salivation, lacrimation, urination, defecation, lahat ng palabas, no. As in wee, poo, everything, no, suka, ganyan. So that those are the side effects of your muscarinic toxicity. Okay? Okay, so next we have your nicotinic agonist naman. Yung mga nicotinic agonist natin, no, we have your nicotine, no? Nicotine as the prototype, no? It's seen in your cigarettes, di ba? And isa sa mga kamukha niyang compound is your varenicline. And your varenicline and lobeline, no, sounds like nicotine kasi, no? They are used for your smoking cessation, no, to wean off patients from nicotine addiction. Okay, another drug that is used as a nicotinic agonist is your succinylcholine. So your succinylcholine actually is a neuromuscular blocker, no, na tinatawag na depolarizing neuromuscular blocker. I'll write this down, no, depolarizing neuromuscular blocker. So, bakit siya naging blocker kung agonist naman siya, no? Ang nangyayari kasi dito, no, it binds to the nicotinic receptors, no? And it constantly stimulate, no? Di ba? It will bind to your NM. NM is seen where nga ulit? Dun sa organ, no? Dun sa muscle, okay? So NM is seen in that, no? Pag nag-bind si succinylcholine dun sa NM receptor, it does stimulation of the muscle. So magko-contract yung muscle, no? Pero si succinylcholine irreversibly binds there. So tuloy-tuloy niyang i-contract si muscle, no? Up to the point na mapagod si muscle. Mapapagod siya and it will cause flaccid paralysis, no? Mapaparalyze siya, hindi mo na siya masistimulate. Kasi di ba for an effective muscle contraction, kailangan mag-rest ng muscle, no? Lahat tayo kailangan mag-rest, no? So yun, kailangan din niya mag-rest, no? So ngayon, dahil continuously stimulated or depolarized, kaya siya depolarizing neuromuscular blocker, mapapagod ngayon yung ating muscle. Hence, called pseudo blocker, no? Na-block niya, parang na-paralyze niya yung muscle na yon. But it is an agonist, no? Remember that. It's a nicotinic agonist. Naintindihan ba? Now, paano pag nasobrahan ka ng nicotinic stimulation? These are the different manifestations, no? Of your nicotine excess. Remember that your nicotine receptors, di ba, are found where? NN sa ganglion, di ba? Diba? If you recall, yung ating ganyan kanina, tsaka ito. So, NN. Okay? So, nandun sila sa ganglion. Ibig sabihin, guys, no, ang nicotinic neural natin, meron siya sa parasympathetic, meron din siya sa sympathetic. Kaya, ang side effect ng excessive stimulation with your nicotinic agents will cause, okay, una, yung parasympathetic side effects natin kanina, yung diarrhea, nausea and vomiting, mga ganon, okay? Plus sympathetic side effects kasi na-stimulate mo pati yung sympathetic nervous system. Naintindihan ba? Kaya at the same time, with the nausea and vomiting and yung mga increased secretion, meron din yan tachycardia, yung mga ganyan, and CNS stimulation, no? So, fasciculation, mga ganyan, high BP, no? So, those are sympathetic nervous system reactions. Mydriasis, as you can see, no? Lumalaki yung pupil size, no? Which is part of the sympathetic nervous system reaction. So, para siyang mixed na parasympathetic and sympathetic nervous system. And the treatment for that would be your atropine. Okay? Your atropine for to counteract the nicotinic excess, plus diazepam, no, for the CNS reactions, and mechanical ventilation for some patients na nagkakaroon ng paralysis. And remember, 'di ba, sabi natin, it can paralyze, 'di ba? Paralyze your muscles. And when you paralyze the muscles, kasama din dyan yung diaphragm, which is a muscle. So hindi sila makakahinga, hirap silang huminga. And what you need to do is to give them pressure, an external force in the form of your mechanical ventilation. So those are your nicotinic agonist natin. So those are under direct acting. Again, ano sabi natin pag direct acting? It acts specifically on the receptors. Ano yung receptors? Muscarinic at nicotinic. Pagka sinabi natin pag sinabi natin non-selective, it binds both to the muscarinic and nicotinic. And ano yung drug na yon? It's your acetylcholine. Pag purely muscarinic, we have the following: betanicol as discussed for bladder atony, nicotinic naman, no? Nicotine ang pinakakilala and used for smoking cessation. Kasama din dyan si succinylcholine as a depolarizing blocker of your NM receptors. Okay? So those are your direct acting. Puntahan natin ngayon ang indirect acting. Okay? Sa indirect acting, we have the following types of drugs. Your alcohol includes your edrophonium, no? Yung edrophonium, ginagamit yan, kilala siya as your tensilon test, no? Yan yung brand name niya. It's used for the diagnosis. Again, it's used for the diagnosis only of myasthenia. Next, we have the carbamates. Okay? The carbamates include your neostigmine, pyridostigmine, and your ambenonium. Okay? Yung use ng ating mga carbamates is for the treatment. Okay? So kung si edrophonium, it's for the diagnosis. Stigmines, no? Pyridostigmines are used for the treatment of your myasthenia gravis. And one important thing to note about your carbamates, no? Makita nyo na they are ending in stigmines, no? Stigmines. Pag narinig nyo ang stigmines, indirect acting yan. O, balik tayo sa mechanism of action. What is the mechanism of action of your indirect acting? It inhibits what? Acetylcholinesterase. And when you inhibit acetylcholinesterase, ang nangyayari, tataas or bababa level ng acetylcholine? Tataas kasi walang nagde-degrade sa kanya. Hence, more parasympathetic reaction or more cholinergic reaction. Nagigets ba yon? Okay, so that is for your carbamates. So myasthenia gravis treatment. We also have this physostigmine. Before, this is used for the treatment of myasthenia gravis. However, one of the side effects of your physostigmine is CNS toxicity, no? Nagkakaroon sila ng CNS toxicity kaya hindi na siya ginagamit ngayon, no? Hindi na siya ginagamit ngayon. And sometimes it can be used for the treatment of atropine, okay? Atropine poisoning. All right? So it's used for the treatment of your atropine poisoning. So next, we have your organophosphates, no? Your organophosphates include yung mga insecticides natin, parathion, malathion, ganyan. And also your war gases, no? Yung tabun, sarin, and soman. So the presentation when you are, so ngayon ang clinical scenario, no, pagka kayo ay nalason with these insecticides will be increase in acetylcholine release dahil wala si ACH, di ba? So wala si ACH. So ngayon dadami, no? Magkakaroon ka ng cholinergic excess or cholinergic stimulation. Meaning, lalabas lang, tandaan nyo lang yung mga dumbbells reaction, no? Diarrhea, urination, mga ganyan. So yun yung presentation ngayon ng patient, no? Think of it that way para mas madali, hindi nyo siya isa-isahin kung ano yung side effect nila. Kasi medyo group lang talaga tong mga cholinergic agonist natin. So the treatment for your organophosphate poisoning is atropine, kasi it's a blocker of your cholinergic nervous system, and also pralidoxime. Your pralidoxime, no, what it does is it prevents, no, yung aging ng pagbind ng acetylcholinesterase, okay? Acetylcholinesterase with that of your organophosphates, no? It prevents the aging. Aging means yung parang mas nagiging strong yung connection nila dalawa. Ngayon, pag naging strong yung connection ng dalawang to, no, hindi mo na ma-release si acetylcholinesterase, no? Hindi masisira si acetylcholine. Dadami si acetylcholine. So, dadami yung cholinergic toxicity. Okay? So, another use of your indirect acting agent is for Alzheimer's, no? Your rivastigmine, donepezil, galantamine, and your tacrine. So, these are used, no, for the treatment of your Alzheimer's. Among these 4 drugs, no, rivastigmine is used as a transdermal patch, no? Ginagamit siya as a transdermal patch. Now, ano ba ang gusto nating mangyari dito? Remember that indirect acting, 'di ba, in general will increase the acetylcholine, 'di ba? Acetylcholine. And pag in-increase mo yung acetylcholine, particularly in the brain, no, it can also help in the management ng ating Alzheimer's disease, no, increasing yung neurotransmission in the CNS. Okay? So visualize and recall lang, no, ang indirect acting natin, ano ang use niya? Inhibit acetylcholinesterase. Meron tayong different drugs, alcohol, 'di ba? Edrophonium, it's used for the diagnosis. Carbamates, ang ending ay stigmines, it's used for the treatment of your myasthenia gravis, no? Physostigmine was previously used pero hindi na siya ginagamit ngayon kasi may CNS side effect. Organophosphate, ano yung mga nandito? Insecticides and yung war gases natin. What is the treatment? Atropine, no? And your pralidoxime. And Alzheimer's, no? To increase the acetylcholine levels, what do you give? Your rivastigmine, donepezil, yung mga tacrine, ganyan. And sino nga din yung transdermal? Si rivastigmine. So those are for your cholinergic agonist. O, di ba madali lang yung ating cholinergic agonist? Habi natin pag cholinergic agonist, divide them into direct acting and indirect acting. Pag direct acting, it acts on the receptor. Pag indirect acting, it acts on the acetylcholinesterase. No? Ano yung receptors natin under direct acting? Muscarinic and nicotinic. So alamin nyo sino yung drugs sa muscarinic, alamin ang sinong drugs ng nicotinic. Na-discuss na yun earlier. Next, sa indirect acting, di ba meron tayong alcohol, carbamates, yung mga organophosphates and used for Alzheimer's, no? Yung mga yon ang ginagawa nila ay ini-inhibit sino? Acetylcholinesterase. So pag na-inhibit si acetylcholinesterase, tataas si acetylcholine. Okay? So that's all for your cholinergic agonist. Punta naman tayo sa blockers, no? Your cholinergic antagonist, no? Basically, no, syempre kung kanina ini-stimulate mo yung muscarinic and nicotinic, ngayon i-block naman natin sila. Punta tayo sa mga muscarinic blockers first. Non-selective muscarinic blockers include atropine, no? Atropine ang pinakakilala diyan. And tandaan niyo yung mga muscarinic blockers natin, most of them will have trop in their name. Okay? It will have trop in their name. Homatropine, no? Tropicamide, no? So yan yung mga palatandaan nyo sa kanila. They are non-selective kasi they can block M1 to M3 or M5, no? Lahat ng mga receptors natin, no, na muscarinic, no? So atropine is the prototype drug, no? It can be used for what? Mydriasis, no, pampalaki ng pupil, no? Particularly si tropicamide, no? Si tropicamide na nandiyan, no? Ito, this one, it's used as an eye drop, no, to dilate the eyes, no? So kung nag-opta rotation kayo, makikita nyo to, nakita nyo na siya and kailangan nyo i-dilate yung patients nyo, di ba? Prior to their OR. Ayan. So you have to dilate them para mas makita yung behind the eyes. Okay? Next, we have your ayan. So atropine, anyari. So on top of your muscarinic blockers na non-selective, we also have your ipratropium and your scopolamine. Your ipratropium, makita nyo yan saan? Okay? Mga COPD patients, no? Sa mga COPD patients natin. Nag-expect ako na answer, wala pala. Kasi hindi ko pala kayo na kakasama ngayon. Recording lang pala to. Okay, ipratropium and tiotropium, okay, are used for COPD patients, no? They are used, no, to bronchodilate the lungs and also decrease the secretion in the lungs. Kasi that's one of the effects of your atropine, di ba? Decreased secretion, no? Opposite of that, your cholinergics, di ba? It causes also bronchodilation, which helps yung mga COPD patient natin to breathe better. Next, your scopolamine is also a non-selective muscarinic blocker. It's used as a transdermal patch dito sa may neck nilalagay, no? Malapit dito sa ears, no? Para sa mga hilo-hilo dyan sa biyahe, no? Ginagamit siya para doon. Okay, for ano yung term na yon? Motion sickness, no? Motion sickness, your scopolamine. Okay? So Your scopolamine is also known as your devil's breath, no? Para lang if in case tanungin yung mga trivia question, devil's breath. Ang palatandaan ko dyan ay, Scopo, andyan na yung devil. Acting na. Scopo, andyan na yung devil, no? Devil's breath. Okay? So your non-selective muscarinic blockers, no? Again, ang key dyan, pag may trop, no, it's a muscarinic blocker likely, no, pagka hindi nyo na alam, kapit patalim. Okay? So atropine toxicity is defined by yung Alice in Wonderland natin, no? Hot as a hair, hyperthermia, decreased secretion, dry as a bone, no? Red as a beet kasi nagkaka-vasodilation ka. Anong receptor yon, di ba? Na nagkakos ng vasodilation, di ba? It is related to yung mga muscarinic receptors natin, no? Pagka blinak mo din sila. Blind as a bat, cycloplegia, no? Mad as a hatter, CNS toxicity. No, yung blind as a bat na yan, no, related siya dun sa ating ciliary muscle, 'di ba? If you recall kanina yung ciliary muscle diniscuss natin for near vision, no? Pero pagka blinak mo yung muscarinic receptors doon, no, ang nangyayari, you will have the inability, no? Mahihirapan ka to focus on closer objects kasi yung muscle mo hindi siya nagko-contract, no? Hindi siya nagko-contract, nagre-relax siya. Hence nahihila yung 'di ba, yung mga suspensory ligaments, nahihila yung lens. So for far vision siya, hindi ka makakakita for near vision. So that's your cycloplegia. Next, ang treatment for atropine toxicity, syempre, temperature control, no? Dahil init na init, cooling blankets. Seizure control, you give diazepam. And also, nabanggit na to kanina, use physostigmine to reverse the anti-muscarinic effect, no? Anti-muscarinic effect. And if you remember yung physostigmine, di ba may CNS effect siya? So itong atropine may CNS effect siya na pwede mo ma-counteract using your physostigmine. So do not use your atropine, no? Your muscarinic blockers in infants, sa mga patients na may acute angle closure glaucoma, and yung mga benign prostatic hyperplasia, or else mas magre-retain sila, no, yung drainage ng ciliary fluid natin sa eyes mas tataas, no, kasi yung drainage ay block. Sa BPH naman, or your benign prostatic hyperplasia, ang nangyayari dyan, mas nagre-retain sila ng urine, no, so mas nahihirapan sila. So that's for your non-selective muscarinic blockers. Punta tayo sa mga M1 blocker. Yung mga M1 blockers natin, may kita kasi yung M1 natin sa ating GI, particularly in the stomach. So it's used for peptic ulcer diseases, no, to decrease the amount of acid secretion. And under your M1 blockers, you have your pyrenzepine. Ang ending ng mga M1 blocker ay M1 zepines, no? Nag-end sila sa zepine. So palitan niyo yung 1 by yung I by 1 para mas ma-visualize nyo, no? M1 blocker, zepine, no? Pyrenzepine and your telenzepine. So your M3 blockers, no, are the following naman. You have your dicyclomine, your hyoscyamine, oxybutynin, and darifenacin. Itong mga to, ginagamit sila for incontinence, no? Yung urinary incontinence. Okay? So those are your M3 blockers. Now, we're done with your muscarinic blockers. Punta tayo sa nicotinic blockers. Again, review. Saan makikita ang nicotinic receptors? Both sa parasympathetic and sa sympathetic. Bakit? Saan nyo nga nakikita ang nicotinic neural receptors? Sa ganglion. Okay, sa ganglion. Kaya sila tinatawag na ganglionic blockers din. So your that's one part of your that's one type of your nicotinic blocker. Mga ganglionic blocker and neuromuscular blocker. Para hindi makalimutan, uulitin natin siya ulit. Ito yung CNS, ito yung parasympathetic, ito yung postganglionic. Dito sa dulo, meron tayong nicotinic muscular, di ba? And dun sa mga ganglion, may nicotinic neural. So yung ganglionic blockers mo, sino sila? Sila itong dalawa, nagblablock dito sa part na to. Yung neuromuscular blockers, yung nagblablock dun sa dulong part. Okay, maliwanag ba yon? So ito siya and ito siya para mas ma-visualize nyo. Okay? So, punta muna tayo sa ganglionic blocker. Your ganglionic blockers include your hexamethonium, no, trimetaphan, and mecamilamine. Itong mga to ginagamit sila dati for hypertensive emergencies, no? Bakit? Kasi remember, dun sa drawing natin kanina, ayan, no? Meron ding sympathetic nervous system na nabla-block si nicotinic neural pag blinak mo. Okay? So ngayon, it's used for excessive sympathetic stimulation. Pero ang nangyayari dyan, no, hindi na sila ginagamit. Bakit? Kasi meron din siyang parasympathetic effect and it causes at dahil doon, nagiging siyang parang ineffective na use for your hypertensive emergencies. So yan, sila yung mga dating ginagamit for hypertensive emergencies natin. Okay? There are some drugs ngayon na mas ginagamit na for this one, no? I-discuss natin sila later. Next, you have your neuromuscular blockers. Yung mga neuromuscular blockers natin, they end usually in curiums and curoniums. No? Pag narinig niyo yung tubocurarine, pancuronium, yung mga rocuronium, mga ganyan, they are blockers of your NM receptors. No? And when you block your NM receptor, ang nangyayari ay nagre-relax. Okay? Nagre-relax yung muscle. Hence, ginagamit sila for surgical procedures para hindi tense yung muscle, mas madaling mag-cut, and also yung respiration ay mas better, no? Mas better kapag mas relaxed yung ating diaphragm, no, for breathing, no. So those are your neuromuscular blocker. Kung kanina, 'di ba, meron na tayong diniscuss na similar na muscular blocker na iba yung ang tawag dito, mechanism of action. Ano nga ang drug 'yon? It's your succinylcholine. Your succinylcholine, 'di ba, it's a nicotinic agonist, but it acts as a blocker kasi what does it do? It depolarizes, no? It continuously stimulates the muscle up to the point na pagod na yung muscle. So mapaparalyze siya. Hindi na siya gagalaw, no? Kumpara natin dito, blinak mo yung receptor, hindi siya gagalaw, paralyzed siya. Both end product is paralysis. Iba lang yung method on how we reach that paralysis or relaxation. Gets ba? So those are your skeletal muscle relaxants. Now, to summarize, no, your blockers, you have your muscarinic blockers, no, M1 blockers, zepines, no, zepine. You have your non-selective, yung atropine, no, trop, no, and your M3 blockers, no. And then you have your nicotinic blockers, your ganglionic blockers, and your neuromuscular blockers. Yung ganglionic blockers natin, ito yung mga ginagamit for hypertensive emergency before. Pero sabi natin, hindi na ginagamit dahil anong blinak niya? Both parasympathetic and sympathetic. Yung neuromuscular blockers naman ginagamit for surgical procedure to relax the muscle, no? And ang mga ending nila ay yung curonium or curiums, no? And one more na kapamilya sana nila but at a different mechanism of action is your succinylcholine, no? So those are your blockers, no? So section synthesis lang, again, ang mga cholinergic agonist natin, ay cholinergic nervous system natin, sa agonist, again, divided into direct acting and indirect acting. Pag direct acting, sa receptor. Pag indirect acting, it blocks what again? Acetylcholinesterase. Pagka-antagonist naman, syempre divide them, depende dun sa receptors natin sa parasympathetic nervous system, which are muscarinic and nicotinic. Right? So that's all for your cholinergic nervous system. Okay, you deserve to take a break and then try to understand further, no, yung mga topics na diniscuss natin, no? Okay, so I'll see you in the next section. Doon naman tayo sa adrenergic nervous system. Okay. Okay, so welcome back na to our autonomic nervous system, no? We now discuss our adrenergic nervous system or adrenergic drugs. Okay? So to start, puntahan muna natin yung mga different ways, the process by which we synthesize our catecholamines, no? Una, magsa-start siya with your amino acid tyrosine, no? Your tyrosine will be uptaken to the presynaptic nerve, no? Your tyrosine with your tyrosine hydroxylase will form your DOPA. ang inhibitor ng tyrosine hydroxylase will be your metyrosine, no? If you remember kanina, 'di ba, yung N3 ng ating tyrosine ay nung ating tawag dito choline doon sa doon sa cholinergic nervous system natin, it's inhibited by your hemicholineum, 'di ba? Ito naman metyrosine. Pero enzyme ang ini-inhibit niya dito. Okay? Your dopa will become dopamine, and since to protect dopamine from degradation, you have to put it, no, in a vesicle, no, in a vesicle. And the uptake in the vesicle, no, itong process to is inhibited by your reserpine. Okay? Your reserpine. Kanina, it's vesamicol, no? We have to delineate the two inhibitors, no, kasi tinatanong din siya minsan. So your norepinephrine, no, when you need it to be released in the cleft, no, you need calcium for it to bind, also to stimulate the presynaptic nerve, no, para ma-release si norepinephrine. Now when you release your norepinephrine, no, it can also have three fates, no. It can be metabolized or degrade. It can be degraded. It can be it can attach to the receptor, no, adrenoreceptors. Particularly, what are the receptors of your under your sympathetic nervous system? It's your alpha, beta, and dopamine, di ba? Your norepinephrine, no, can also be reuptaken dun sa presynaptic nerve natin, no, by this receptor, no. It's a transporter that will reuptake the drug, the catecholamine, to the presynaptic nerve para reuse mo siya or ma-recycle mo siya. And the drugs that inhibit that includes cocaine and your tricyclic antidepressants, no. Kaya dito, no, itong dalawang to, no, if you recall yung effect ng cocaine, no, syempre increased stimulation kasi madami kang norepinephrine dun sa cleft na pwede mag-bind dun sa receptor. Kaya parang hyperactive ka, no? It's a board questions before nung pharma boards namin, no? So what is, ano daw yung drug na can be similar to amphetamine in terms of the end effect? Parang ganun. Okay? So that's all for your synthesis, no? You have to differentiate the two, okay? And the inhibitors of both. Okay, let's start with the sympathetic nervous system. So for the sympathetic nervous system na drugs, no, we have your sympathomimetics and your sympatholytics. Your sympathomimetics, ang tawag, other term sa kanila ay adrenergic agonist or sympathetic agonist, no. They mimic, no, the catecholamines in the body. Kasi sa sympathetic nervous system, ang main driver would be your catecholamines. So they act like, no, the catecholamines. Yun yung mga drugs na sympathomimetics. While your sympatholytics, no, these are adrenergic, no, antagonists, adrenergic or adrenergic blockers, no. So these are your sympatholytics. Let's start with your sympathomimetic, no. Siyempre, with your sympathomimetic, pasok dyan yung ating mga direct acting, yung indirect acting. Pag sinabing direct acting, no, again, tulad nung kanina sa cholinergic nervous system, they act on the receptor itself, no? It's either alpha receptor, beta receptor, or dopamine, kung ano mang receptor yan na nasa adrenergic nervous system. While your indirect acting, so later on i-explain natin to, they act on another enzyme, no? Let's first discuss yung ating sige, before moving to the next pala, sorry. Yung sympatholytics naman, no, they are divided depende doon sa receptor na blina-block nila. Okay? Punta muna tayo sa ating direct acting na sympathomimetics. Again, pag direct acting, 'di ba? Doon siya sa receptor mismo. Your direct acting can be non-selective, selective, no? Pag sinabing non-selective, wala siyang pinipili, alpha man yan, beta man yan, alpha 1, alpha 2, beta 1, beta 2. Okay? Either of those, no, it can stimulate. Okay? Example niyan, yung ating mga catecholamines. So, syempre sila yung prototype. So, kayang-kaya nilang ma-stimulate lahat. You have your norepinephrine, epinephrine, and your dopamine. No, pinaka ginagamit sa kanila, no? Actually, they are used usually as pressors. No? Kung makita niya sa critical care, no, lalo na sa mga patient natin na in shock, no? the following are used. Particularly si norepinephrine. It's the first line agent used for septic shock. Ayan, lagi kami sa sa wards no kapag yung patient septic shock o start na ba natin with norepinephrine no? Ang mangyayari nun ay kailangan mong ibigay no at a certain rate no. Para mag-increase yung blood pressure nila, no? Another drug that can be used as a pressor is your epinephrine, no? Your epinephrine can be an add-on to your norepinephrine, no? Usually sa wards ang ginagawa namin, norepi muna and then you add your vasopressin and then you add your epinephrine as a third pressor, no? Para ma-increase yung vasoconstriction at mapataas si blood pressure. Okay? So kung again, sulat natin para hindi niyo makalimutan. Si norepi, ginagamit siya for septic shock, 'di ba? Septic shock. Si epinephrine, ginagamit to usually sa anaphylactic shock. Anaphylactic shock. Yung anaphylactic shock, 'di ba? Na-discuss natin, it's an excessive stimulation from histamine, no? And epinephrine, as discussed previously, it is a physiologic antagonist of your histamine, okay? And your dopamine, your dopamine can also be used for septic shock, especially if mababa yung renal function natin, okay? It has dose dependent actions, Pag mababa yung dose, pwede siya for dopamine stimulation. When you increase at a moderate dose, it will act on beta-1 receptors. Pero when you increase further the dose, mas tataas siya and it will stimulate your alpha-1 receptors na rin. Okay? So those are your catecholamines. Punta naman tayo sa ating alpha-1 agonist. Selective, nasa selective na tayo ha. So punta tayo sa alpha-1 agonist. Your alpha-1 agonist will involve yung mga pangsipon, ito yung mga phenylephrine, yung mga zolines, zolines for anong tawag dito? Para sa sipon, what it does, kapag sinabi nating alpha-1, saan mo nga makikita yung alpha-1? Sa mga blood vessels natin, And remember, kapag tayo ay may nasal congestion, ang nangyayari kasi diyan, vasodilated yung mga blood vessels natin dito sa may nasal area, nasal cavity, ganyan. So nagiging silang makakapal, boggy, so hindi mo ma-drain, nang mabuti yung sipon. So ngayon, what you want to do is you vasoconstrict that using your phenylephrine, And yung mga zolines natin, yung oxymetazoline, xylometazoline, and what it does is bababa yung congestion. Magbabasoconstrict, mababawasan yung nasal congestion natin. Ang paratandaan ko dyan is zolines, zipon. Okay? Zipons. Okay? Yung mga zolines and phenyllephrines. Okay? Next, we have your alpha-2 agonist. Ay, bakit ayaw mag-next? Oh, ayaw mag-next. Okay. You have your alpha-2 agonist, your clonidine and your methyl-dopa. So your clonidine, kapag and your methyl-dopa, pag narinig yung alpha-2 agonist, yung alpha-2 agonist, it's really a regulator of your sympathetic nervous system. So ang ginagawa kasi nito, una, pag na-take mo yung clonidine, for example, tinake mo siya, syempre ma-absorb yan dahan-dahan to the bloodstream. First, it will meet yung mga alpha-2 receptors na nandun sa blood vessels. And when it meets yung alpha-2 receptors na nasa blood vessels, ang ginagawa niyan, it will vasoconstrict them. Di ba? Alam natin si alpha-1, it can cause vasoconstriction. Alpha-2 will also have peripheral vasoconstriction pagka yung peripheral alpha-2 receptors yung na-stimulate natin. But once it reaches the central nervous system, your alpha-2 agonist will become a regulator. Regulator. Okay? It will become a regulator, Ang gagawin nito, it will decrease the release of your norepinephrine, Yung norepinephrine from the itong drawing na to ay presynaptic cleft ha, yung parang kanina. So it will decrease the release of your norepinephrine from the presynaptic cleft, hence lower catecholamine levels will cause now your vasodilation. So ganun yung effect niya. So, ngayon, ang clonidine, ginagamit kasi yan for for hypertension, di ba? Iyon yung nilalagay sa ilalim ng dila para sa mga patients na matataas yung BP greater than 180s, mga ganyan. So, what it does is, when you take it, nagkaka-transient vasoconstriction, transiently tataas ng onte yung blood pressure, pero at the end of everything, no, bababa siya because it regulates, no? Regulates. Ang palatandaan ko dyan, alpha 2 for regulator. Okay, regulator, okay, of your catecholamine release, no? It's the same with your methyl dopa. Your methyl dopa is another drug that is used for pregnant women, no? For pregnant women na may high blood or your hypertension in pregnancy, no? Ano ba yung mga drugs na ginagamit for blood pressure lowering sa mga patients na buntis? It's your LMNH, no? Kasama diyan sila betalol, si methyl dopa, no? Si nifedipine and si hydralazine. Okay? So those are the 4 drugs that can be used for your hypertension in pregnancy. So next, puntahan naman natin ang mga beta agonist natin. So tapos na tayo sa alpha 1, alpha 2, no? Punta tayo sa beta agonist. Pag sinabing beta agonist, meron tayong mga non-selective beta agonist, meaning beta 1 or beta 2 kaya nilang ma-stimulate. Example niyan ay si isoproterenol, no? Again, para lang ma-recall natin, saan nga makikita ang beta 1? Sa heart. Saan ang beta 2? Sa lungs, di ba? At tandaan nyo, meron kang 2 lungs, meron ka lang 1 heart. Okay? Para hindi nyo lang makalimutan yung basic concept na iyon, no? Isoproterenol can stimulate the heart and the lungs, no? Before given siya for asthma, pero now hindi na kasi it can cause also stimulation ng beta 1. So it can cause tachycardia. So ngayon, meron tayong mga beta 1 selective drugs na agonist, no? Yung ating dobutamine. It can be used, no, sa tinatawag nating dobutamine stress test, no, to assess the function of the heart, no, in para siyang pharmacologic stress test, no. It increases the heart rate, no, to mimic yung ating parang increased physiological stress, no, kapag tayo ay tumatakbo or kunwari may ginagawa, no, para makita natin kung may barado ba na parang artery papunta dun sa ang tawag dito sa puso natin, no? So that is an example of your pharmacologic drug that is used for your pharmacologic stress test. Okay, so next, after beta 1 selective, punta tayo sa mga beta 2 agonist natin. Yung beta 2 agonist natin, di ba kita sila sa lungs? And kapag in-stimulate mo to, what does it do? It bronchodilates your lungs, no? Bronchodilate your lungs. Hence, mas makakahinga ka. And ginagamit sila for what? For asthma. So ito yung mga drugs natin, yung mga terols, no? Salmeterol, formoterol, no? Albuterol or your salbutamol, no? In English. Tapos si Saba and Labasmo for asthma. And yung RIT, ano yung RIT na yan, no? Ang palatandaan ko dyan, ritocolytic, no? Ritocolytic. Ginagamit sila pampakapit ng bata, no? Pampakapit ng bata, no? Para sa mga patients na may preterm labor, no? Kung gusto mong patagalin muna yung baby dun sa tiyan, no? You give these beta 2 selective agonists. And if you remember, di ba kanina sa uterus, makikita mo si beta 2 receptor din, no? Sige, uterus yan kunwari, ha? So beta 2, no? It relaxes the uterine muscles, no? Example ng mga yan, kaya siya ritocolytic, no? Ritodrine, isoxsuprine, and your terbutaline. Those are the 3 that can be given as tocolytic agents natin. So done na tayo with your direct acting. Again, direct acting, no? What does it do? It stimulates the receptors. Anong receptor ang nasa sympathetic nervous system? Alpha, beta, or well, alpha, beta muna. Alpha and beta, no? Yung mga drugs natin na non-selective alpha or beta are your prototype, di ba? Si catecholamines natin, norepi, epi, and dopamine. Tapos meron din tayong mga selective. Pag selective, syempre pipili siya. Alpha 1 ba? Alpha 2 ba? Or beta 1 or beta 2? Pag alpha 1, di ba? Alpha 1, para siyang, ang ending yan, zolines, no? Zolines. So you need to vasoconstrict, di ba? Zolin-sipon, no? Zipon for your alpha 1 agonist. Alpha 2 agonist, you have your clonidine. Your clonidine ginagamit for high blood. Pero sabi ko, di ba, it's a alpha 2 for regulator. Regulator. Okay? As a regulator. And then beta agonist natin, beta 1, no? Dobutamine for pharmacologic stress test. And si beta 2 selective for your asthma. Okay? Yung mga terols natin. Okay, so next na-discuss natin ay kung kanina direct acting, di ba, they act on the receptors. Ang mga indirect acting naman, no, what they do is they either increase the release of your catecholamine or they inhibit the reuptake. No, what kasi di ba dito sa receptor natin, di ba, na-release yung ating norepinephrine, no, catecholamines, no, and stimulate ang stimulant ng ating release ng norepinephrine includes your amphetamines, no? So ito ay isang drug that can be used to increase the level of norepinephrine in the cleft. Now, one more thing for you na kailangan maalala para mapataas yung level ng norepinephrine or catecholamines mo is to inhibit the reuptake. Di ba kanina may reuptake mechanism na tinuro ako? So what do you give, no? Actually, nabanggit na siya kanina. What blocks the reuptake? Diba? It includes your TCA and your cocaine. No? Kaya kanina, sabi ko, no, yung board exam question namin before sa pharma, no, ano yung similar? Kaya na end effect ng aling drug yung may similar effect to amphetamines. No? Kasi end effect nila is to have norepinephrine more seen in the dun sa cleft natin. Okay? So these are your indirect acting. They don't act on the receptor itself, but they increase the level of your catecholamines. Okay? Those are for your indirect acting. Next, for the sympatholytics, we have your blockers, no? Alpha blockers and your beta blockers, no? Syempre, kapag pinag-usapan kasi na sympatholytic, di ba? Sympathetic nervous system, ano yung mga receptors? Alpha and beta lang naman. And pag lytic or lysis, syempre, these are blockers, no? Alpha blockers and your beta blockers, no? Pag sinabi nating alpha blockers, they can be divided into non-selective, your selective alpha 1, and your selective alpha 2. So your non-selective alpha blocker, meaning it also activates your, it also blocks your alpha 1 and your alpha 2, no? Ginagamit itong dalawang ito, si phenoxybenzamine and phentolamine, no, sa ating pheochromocytoma, no? Pheochromocytoma. Diba it's a tumor in the adrenal gland that causes excessive catecholamine release, okay? Your pheochromocytoma. Okay? Pheochromocytoma. So those are your non-selective alpha blocker. Ngayon, ang difference ng dalawang yan, yung isa ay reversible, yung isa ay irreversible. Ang palatandaan ko dyan ay yung phento, no, ay reversible. Alam niyo yung door na ganito yung itsura niya, yung reversible na pumupunta sa other side and then sa other side. So again, reversible phento. Okay, reversible phento. So phentolamine, okay? Si phenoxybenzamine ay isang irreversible na na non-selective alpha blocker. So those are the main that is the main difference ng dalawa. Kung sino yung irreversible and irreversible. Okay? Next, you have your alpha 1 blockers. Alpha 1 blocker and indozine. Example, prazosin, terazosin, yung mga ganyan, doxazosine. And what it does is it saan nga muna ang alpha 1? Sa vessels, di ba? Ang normal action niya pag in-stimulate mo ay vasoconstriction. Pero pagka blinak mo siya, what does it do? It vasodilates. So your zosines are vasodilators, no? They are vasodilators. Okay? So example nun, di ba ginagamit sila for high blood. Okay? Para magkaroon ka ng anong tawag dito? Decrease in the peripheral resistance. Kasi di ba if you remember your high blood pressure, your BP, di ba, is equivalent to your cardiac output times your total peripheral resistance. And ito, pag bumababa to by vasodilating the blood vessels. So important sila doon, no? Terazosin. Yan. Nakikita ko tong mga to minsan kapag patients na very resistant hypertension, no, ina-add namin dun sa medications nila. Next, you have your selective alpha-2 receptors. Your selective alpha-2 receptors include your rauwolfsin and your yohimbine. Dati ginagamit sila for high blood pero hindi na sila ngayon masyadong used, no? Rauwolfsin and your yohimbine. Okay? Before nagpipiyok. So before, not naman before, your tamsulosin is also associated with what you call your intraoperative floppy iris syndrome or your IFIS, no? It's involved parang ang nangyayari dito yung iris ay nawawalan ng parang tone, no? Kaya siya naging tinatawag na floppy iris as you can see in the picture. So that's involved. It involves your tamsulosin use, no? Tamsulosin for your floppy iris syndrome. Okay, those are your alpha-1 blockers. Okay, one important thing to note, di ba? Kung ang alpha-1 blockers ay zosin, ano nga ang alpha-1 agonist? Zoline, di ba? Oxymetazoline, di ba? Silometazoline. Kapag blocker, it's zosin, prazosin, tamsulosin, no? Doxazosin, mga ganyan. Okay? So those are your alpha-1 blockers. Okay, next. So punta naman tayo sa mga beta blockers natin. So yung beta blockers natin divided sila into your cardioselective, yung with intrinsic sympathomimetic activity, and yung ating with membrane stabilizing activity, no? Yung mga cardioselective natin, it's parang defined or encompassed by your mnemonic na BEAM-NC. So you have your bisoprolol, no? Bisoprolol, esmolol, acebutolol. You also have your metoprolol, your nebivolol, and your celiprolol, no? So those are your cardioselective. While your ISA, no? Sila wait lang, balikan natin. Ang mga cardioselective sila yung beta-1 selective, no? Hindi sila nag-stimulate nung beta-2 receptors natin, no? Which can aggravate kasi asthma, no? So magandang gamitin ito for asthmatic patients. Yun namang mga may intrinsic sympathomimetic activity, no? Intrinsic sympathomimetic, parang meron silang sympathetic effect, no? Added sympathetic effect, no? Such as it can really prevent yung mga bradycardia in patients with hypertension and angina, no? Very useful sila doon. And also it prevents bronchoconstriction sa mga patient with asthma. So example ng drug na to, yung mga cartiolol, no? Labetalol, acebutolol, and your pindolol. Usually yung mga nandito sa clap na to ay yung mga drugs na may names na nagsistart with the following letters pero very uncommon yung name, no? Para lang hindi nyo sila makalimutan and ma-interchange. Yun namang MSA or membrane stabilizing activity. So some of your drugs kasi they have yung local anesthetic effect, no? Kaya tinatawag na some of your beta blockers will have local anesthetic effect, no? And hence kapag ginamit mo kasi sila for topical use sa eyes, no? Pwede ang mangyari hindi mapansin ng eyes mo na may damage sa kanya or may sira sa kanya. So nagkakaroon ng corneal abrasion. Hence, yung mga beta blockers na pwedeng gamitin for topical eye drops would only include cetimolol, cetimolol, and your betaxolol, no? Betaxolol. So these are the only two na walang membrane stabilizing activity. Hence, best silang gamitin for your topical eye drops. Okay. Some notes lang dun sa beta blocker use natin, no? It masks kasi yung symptoms of your hypoglycemia. Lalo na mga patients natin na may diabetes, for example. Kapag ikaw ay hypoglycemic kasi yung body mo will then react via sympathetic nervous system, no? Increase yung heart rate, increase yung sweating, palpitation, mga ganyan. Pero dahil na-block mo yung sympathetic nervous system, particularly yung mga palpitations, ganyan, no? Hindi mo mapapansin na, oh my God, hypoglycemic na pala siya, no? Mababa na pala yung level of sugar niya sa body, no? Another use of your beta blocker is for your hyperthyroidism, di ba? Particularly anong tawag dito? Propranolol, sorry, natagalan yung brain ko. So, propranolol, no, for use for hyperthyroidism, no? It also kasi helps in the conversions of your T4 to T3, no? Para mas makatulong dun sa hyperthyroidism natin. Okay? Blocks the conversion of your T4 to T3, I mean. So interactions also with your CCBs, particularly your non-dihydropyridine type, no, na mga calcium channel blockers, pag minix mo sila with beta blocker, it can cause further, no, depression of the heart, no, mas babagal yung heart, bradycardia, and it can also cause heart block. Okay? And lastly, yung sotalol, no, it's potassium channel blocker, but it's also a beta blocker, no? And pasok siya dun sa class 3 anti-arrhythmic effect, no? It's an anti-arrhythmic drug then. Okay? So that's all for your autonomic nervous system. Okay? So I hope you learned a lot dun sa autonomic nervous system natin. And next na topic natin would be our cardiovascular drugs. So you have to take a break muna ulit ngayon, no? But before taking a break, let's just have a quick rundown nung kanina, yung ating mga sympathetic nervous system, your sympathomimetics and sympatholytics, di ba? Under sympathomimetics, meron tayong direct acting and indirect acting. Yung direct acting natin, nag-a-act sila mismo dun sa receptors natin na alpha or beta. Yung mga non-selective na sympathomimetics, sila yung mga catecholamines natin. While your alpha-1 selective, 'di ba? Sila yung para sa zipon, 'di ba? Sila yung mga zoline. Alpha-2 agonist naman natin, alpha-2 as regulators, 'di ba? Si clonidine and si methyl-dopa. Now, your beta-1 agonist naman si dobutamine for the stress test, 'di ba? It increases the heart rate kasi it's a beta-1 agonist. Beta-2 agonist naman are your drugs for asthma, 'di ba? So those are your sympathomimetics. Sympatholytics or your sympathetic blockers, syempre i-block mo lang yung mga receptors ng sympathetic nervous system, particularly alpha-1, di ba? Alpha-1 blockers include your zosines, no? They are used for vasodilation, di ba? Kasi opposite yon ng effect ng alpha-1, no? It's used for hypertension. Next, alpha-2 blockers, hindi na ginagamit, si yohimbine and rauwolfsine. Next, beta-1 beta blockers, di ba? Beta-1, no? And then yung non-selective, you have your, non-selective muna pala. Yung non-selective beta blocker natin, si isoproterenol, dati for asthma, pero dahil binablock niya both, hindi na siya ginagamit for that kasi pwede siyang mag-cause ng effect dun sa heart. Next, beta blocker or beta-1 blockers are your olols, di ba? In-explain natin kanina. And your beta, yan, yung mga beta blockers natin. So those are used for your yung ating mga hypertension and yung mga cardiac conditions natin. Okay? Which we will be discussing in the next slides. Okay? You rest muna for 5 minutes and then let's start cardiovascular drugs. Okay. Okay, so welcome back guys to our top-notch pharmacology. Today we will be discussing ating mga cardiovascular drugs naman, no? So for the cardiovascular drugs, we will be dividing them dependent dun sa condition or disease, no? For example, hypertension, angina, etc., heart failure, mga ganyan, okay? To start, we go to hypertension, no? Hypertension, di ba, is an elevation of the blood pressure in the body, no? It can be due to a primary hypertension, which is hindi natin alam kung ano yung cause, or a secondary hypertension na meron tayong sakit na iba, for example, renal disease, that can cause an increase in the blood pressure of the body, no? So, ang main goal natin dito is really to control yung main controller ng body natin ng blood pressure, which is the RAAS, no? Siya yung long-term controller ng blood pressure natin, which is your renin-angiotensin-aldosterone system. Now, this system can be inhibited by the following drugs. You have your ACE inhibitors. Sila yung mga prils natin, no? Yung captopril, mga ganyan, lisinopril, etc. While your ARBs are those that end in your sartans, no? Sartans, yung losartan, etc. Okay? So, and we also have your renin inhibitor in the form of your aliskiren, no? Yan, aliskiren. Now, your ACE inhibitors or your prils, ang pinakalaging tinatanong nila, what is the side effect, no? It can cause your idiosyncratic cough, no? And angioedema. And when you have that, no, you have to really give or shift the patient to an ARB or your sartans, no? So which will have lesser cough as a side effect. Now, we also have a new drug, your aliskiren, no? It's a renin inhibitor. So, ang palatandaan ko dyan is aliskarenin, no? Aliskarenin. It's a renin type of inhibitor. So, it's a contraindication it's contraindicated in patients na pregnant. Okay? So, the main goal, no? Kapag blood pressure control, ang una mong isipin, first line would be your RAAS, no? RAAS antagonists. Okay? Next would be to control the diuresis, no? To control the blood volume, no? What you want to do is to decrease the blood volume or the parang yung total volume in the body, in the intravascular space, para bumagsak yung cardiac output. Kasi if you recall, yung blood pressure natin is cardiac output times the total peripheral resistance. And your cardiac output is, okay, a factor as a product of your heart rate and your stroke volume. And your stroke volume, dito pumapasok yung blood volume din natin. No? Pag binabaan mo yung blood volume, bababa yung stroke volume, bababa yung cardiac output. And para magawa mo yun, paihiin mo yung patients. The most common diuretic used for hypertension are the following. Yung mga thiazide diuretic natin, no? And your loop diuretics. Yung mga thiazide diuretics natin, no, kasama dito yung hydrochlorothiazide, yung mga ganyan, no, indapamide, no. And then your loop diuretics naman, sila yung high ceiling diuretics. Sila ay very strong they can cause very strong diuresis na papaihiin talaga nila yung pasyente. No, the main difference between the two is yung location nila. If you recall yung nephron natin, no, ay yung buong tubules natin. So we have your your proximal convoluted tubule, which is this one, letter A, your loop of Henle, your distal convoluted tubule, and your collecting duct, which is your D. No? Ang function ng thiazide ay dito sa letter C. Your loop diuretic, ang function niya ay dito kay letter B, no? Sa loop of Henle. And the main difference between the two is yung transporters. No? So dito sa may loop of Henle, you have your sodium, potassium, and 2-chloride co-transporter. No? As you go along, bawasan mo yung number of electrolytes na nandun sa transporter. No? Remove now your potassium. It becomes your NaCl. No? Actually, yung mga drugs dun sa collecting duct later on, yung mga aldosterone antagonists, yung mga potassium-sparing antagonists natin, ang binablock ng mga yan ay sodium na lang. So as you go along, no, dun sa tubule, nababawasan yung nandun dun sa transporter natin. Okay? So, one of the side effects of your thiazide diuretic is yung hypergluc. No? Hypergluc. Gluc means, no, it's a mnemonic for hyperglycemia, hyperlipidemia, hyperuricemia, and hypercalcemia. While for your loop diuretic, tanggalin mo lang yung hypercalcemia. So, hyperglu. Now, si thiazide diuretic, meron itong function niya na to, yung hypercalcemia, nagkakaroon siya ng use in patients with idiopathic nephrocalcinosis. No? Ibig sabihin, madami yung level of calcium dun sa tubule. So, na pwedeng mag-cause ng stone formation. So what your thiazide does is nire-reabsorb niya yung calcium from the tubule. Now, if na-reabsorb yung calcium from the tubule, pwede siya mag-cause ng hypercalcemia. So ganun ko siya ini-imagine para hindi ko makalimutan na it can also cause hypercalcemia as a side effect. Okay, next would be your sympathoplegics. Your sympathoplegics can be your alpha agonist, no? Kasama dyan sina clonidine and methyl dopa natin. Remember, alpha-2 agonists are called regulators, di ba? Okay, so clonidine and methyl dopa. And your alpha blockers naman, example ng alpha blockers natin yung mga zosines, di ba? Zosines. Okay, prazosin, terazosin, no? They are alpha blockers and it cause what? Vasodilation. When you cause vasodilation, you will decrease the peripheral resistance, decreasing now your blood pressure. Okay? So, but however, ang alpha blockers natin, they can be associated with your first dose syncope. No? The first time that you give it, it will cause increased vasodilation. Biglang babagsak yung blood pressure na kung saan tatayo lang yung patients natin, biglang nahihilo na sila. Okay? So that is for your alpha blockers. And also, syempre, yung beta blockers natin na diniscuss natin earlier that it can decrease the heart rate. No, when you control the heart rate, you also control the cardiac output. Diba dun sa BP natin, sabi natin BP is equal to cardiac output times the total peripheral resistance. Saan papasok yung heart rate? Sa cardiac output. Okay? Remember that your beta blockers are not used for your ADHF or your patients with acutely decompensated heart failure. Kasi syempre bagsak na nga yung heart nila, no, hindi na nga gumagana na maayos, bibigyan mo pa siya ng beta blocker. So mas ma-block yung pag-pump ng heart, no? Mas ma-depress mo yung heart. Next ay yung ating mga vasodilators. Now we have your older vasodilators, your CCBs and your parenterals. Before gumagamit tayo ng hydralazine, no, minoxidil, and your diazoxide. Your hydralazine, ang main function niya is it alters yung calcium metabolism. Hence, 'di ba ang calcium, 'di ba need siya for contraction, no? When you alter that one or you block that one, wala kang calcium na magagamit. Magre-relax yung muscle, hence the vasodilating effect. Minoxidil naman, ang ginagawa niya would be to block the potassium channels. So ang nangyayari doon, nagkakaroon ka ng hyperpolarization, hence hindi mo ma-depolarize yung muscle. No? Pag na-depolarize mo kasi yung muscle, mas nagko-contract, di ba? Pag hyperpolarize siya, sobrang relax niya, no? To the point na hindi na siya magko-contract. So that's how minoxidil works. No? Minoxidil is also used for, saan nga? Yung balding hair, no, para mag-increase yung stimulation ng hair production. Okay. Next would be your CCBs. Your CCBs can be divided in your non-dihydropyridine type and your dihydropyridine type. Yung mga non-dihydropyridine type, we have your verapamil and your diltiazem. So ang palatandaan ko dyan, no, verapamil V for cardiac. Cardiac. I-drawing yung letter V. Okay, verapamil. Okay, for the heart. Alright? So yan yung kaya sila it has a greater function in the heart compared to your dihydropyridine type na equal lang yung cardiac and vascular effect natin. Also, your verapamil and diltiazem, they are involved with gingival hyperplasia. Plasia yan, ha? Hindi plasma. Okay, and then dihydropyridine type, they end in dipines, no? Yung mga amlodipine, okay? It has more vascular effect, no? Okay? And your amlodipine can also cause your gingival hyperplasia. Okay? Among these drugs, no, actually, kapag in practice, tatanungin kung alin yung pinaka laging ginagamit na nakikita ko sa OPD every time, left and right, no, we have your CCBs, your amlodipine, no, and as well as your sartans, yung mga ARBs natin, no. Makikita mo dyan, losartan 100, amlodipine 5 or 10, mga ganyan. And then, on top of that, you add your diuretics kung hindi talaga kaya. Particularly, yung mga thiazide diuretics natin can also be used, okay? Next, we can also give parenterals. No? These are actually hindi masyadong ginagamit, yung nitroprusside, which increases the nitric oxide synthase, no? Hence causing vasodilation kasi it does alter yung CAMP metabolism din natin as well. Kaya nagkakaroon ng relaxation due to the decreased levels of CAMP in the system. No? Now, it's used for hypertensive emergency, but it is also used for your cyanide toxicity. It can also cause cyanide toxicity, I mean. Okay? It can cause cyanide toxicity because in the molecule of your nitroprusside, meron dyan CN. Okay? One more thing is your phenyldopam. Your phenyldopam also is a vasodilator that can also increase the renal blood flow because it has an action on your dopamine receptors. And when you when you stimulate the dopamine receptor, it can increase the renal blood flow as well. Okay? So, ayan. So those are the drugs for your hypertension. Okay. Next, we go to angina. Your angina, no, is a clinical manifestation wherein sumasakit yung dibdib natin, no? Mabigat yung pakiramdam sa dibdib. Ano ang nangyayari? Ano ba yung pathophysiology behind it? What happens is meron kang decreased oxygen supply, no? Ibig sabihin mababa yung oxygen supply to the heart, causing the angina, no? Or the heart chest pain, no? Or masyadong mataas yung demand ng body mo for oxygen, kaya nauubusan ng supply si heart, no? So pwedeng increased demand or low supply for oxygen. Okay, let's start. The drugs for angina. Now, for the drugs for angina, you give, syempre, ang gusto natin is to dilate the coronary vessels para mas madaming blood flow doon sa ating heart, no? Di ba? Kasi yun yung blood supply ng ating heart, no? So what you do is you give the vasodilators, no? We have your nitrates, no? Example dyan, si amyl nitrite, no? Your amyl nitrite is not really given for angina, pero pwede siyang gamitin doon, pero mas ginagamit siya for your cyanide poisoning, no? It's an inhalational substance that can cause, no? It's an inhalational substance that can cause the conversion of your cyanide molecule, no? Ano niya yan, i-oxidize, no, para mas madali siyang ma-excrete, no. Kasama din dito si sodium nitrite, no, as part of the ano tawag dito? The cyanide kit, no? So amyl nitrite, sodium nitrite, and your sodium thiosulfate para maging, yung sodium thiosulfate, ang goal nun ay para mas maging water soluble yung ating cyanide molecule, no? So your nitrates, no, particularly your nitroglycerin, your ISDN, and your ISMN. Ito yung mga lagi ko nakikita sa clinic, no, na ginagamit for patients with angina, no, para magkaroon ng vasodilation. Pag nag-vasodilate ka, mas madaming blood flow. Yung blood flow ay yung blood ninyo would carry more oxygen to deliver the oxygen to the heart, okay? So itong mga nitrites natin na to, no, hindi sila pwedeng maibigay with sildenafil. Okay, sorry, na-cut yung part na to, no? So, again, your ISDN or your ISMN should not be given together with your sildenafil because it can cause, no, excessive vasodilation and can cause hypotension, no? Next, punta tayo sa mga CCBs, no? Your CCBs can be your non-dihydropyridine type of your calcium channel blockers, and it includes your verapamil and your diltiazem. Itong verapamil and diltiazem, ang goal nito is to increase the vasodilation, no, doon sa ating coronary blood vessels, and then it will also cause slowing of the heart rate, no, para mas ma-decrease yung demand doon sa nung heart doon for more oxygen. Okay? Next, similar, no? Beta blockers also depresses the demand for oxygen. And lastly, we have your metabolism modifiers. We have your trimetazidine, we have your ranolazine, and your ivabradine. So among these three, no, yung ivabradine yung ginagamit din sa ating angina, no? It acts on the funny sodium channels na tinatawag natin. Okay? Your trimetazidine, ang ginagawa niya, it inhibits your beta oxidation ng mga fatty acids natin, and in the end it enhances yung glucose oxidation, kaya ang nangyayari it prevents yung decrease in the ATP, no, sa ischemic and hypoxic state, lalo na pag mababa yung oxygen doon sa heart levels natin. So meron kang additional sources of energy for the heart muscles. Okay, so those are drugs for angina. Next, cardiovascular drugs. We go to the heart failure naman. Pag sinabing heart failure, no, again, it's a mechanical problem in the heart, no, wherein pwedeng may mechanically there is a depression in the function of the heart to be able to circulate yung ating blood flow, no, along the body, no. One of the main therapeutic strategies is to give yung inotropic drug, syempre para ma-increase yung contractility. Next is to give also your vasodilator, no. Bakit? Kasi ayaw natin na mahirapan yung puso natin na mag-pump ng blood, okay, palabas ng heart, lalo if masikip yung daluyan ng dugo, no? Kasi pag masikip yan, mahirapan si heart, no? You have to vasodilate it as well, no? Aside from increasing the contractility. Next is to give diuretics then, no? The more that you give diuretics, the more na mas bababa yung blood volume, mas madaling ma-circulate yung blood flow doon sa body kasi overloaded ka na nga minsan, no, ng fluid sa katawan. Mapapansin nyo yan sa mga patients na may heart failure, manas na manas, hingal na hingal, ayan. So pagka humiga sila, no, yung tinatawag na orthopnea, no, hindi sila makahinga ng mabuti, and minsan magigising sila na parang lunod na lunod, no. That's your paroxysmal nocturnal dyspnea, no. So these are some clinical manifestation na pwedeng ma-address with the following drugs. And also, syempre, bigay mo rin yung mga ACE inhibitors natin, no? Which were discussed then previously, similar to your heart failure, and your beta blockers para hindi masyadong ma-overload yung function ni heart. Okay. Let's go to the inotropes first. Your inotropes will increase, di ba, the heart pumping mechanism of your cardiac muscles, no? Pinakakilala dyan ay si digoxin, no? Your digoxin, no, will inhibit your sodium-potassium ATPase pump. It has a very narrow therapeutic index. Di ba sabi ko kanina, yung therapeutic index is the difference between your TD50 and your ED50. Ngayon, ibig sabihin, sobrang unti lang ng window mo para maglaro ng mga different dosages natin for digoxin, no? Hence, it has a narrow therapeutic index, no? And it can also cause arrhythmogenesis with electrolyte derangements, no? Particularly your the following, no? Okay. So kaya ko siya ginanyan, no? I-drawing niyo siyang ganyan mismo, no? Kasi potassium, magnesium, and oxygen, no, will na mababang levels, hypocal, hypomag, hypoxic, hypoxia, no, can precipitate, no, digoxin toxicity. While calcium na mataas, okay, hypercalcemia, can precipitate digoxin toxicity as well, no. Ang palatandaan ko dyan is kamoka, no, kamoka. Okay? So next, syempre, one inotrope din na kilala natin, no, kasama dun sa na-discuss earlier, would be your dobutamine. Your dobutamine is a beta-1 agonist. No? It's a beta-1 agonist and it can increase the pumping mechanism of the heart. No? It's used for cardiogenic shock. No? Nakita ko na rin na ginamit ito in the wards, no, to increase the ang tawag dito, blood pressure that is due to the failing heart, no? To increase yung contractility ng heart. And lastly, you have your PDE inhibitors. You have your milrinone and your inamrinone. Remember that your CAMP, pagka ito ay na-degrade, no, by your phosphodiesterase, no, it will become your AMP, no, na walang action. So ngayon, pag in-inhibit mo yung PDE, no, ang mangyayari, hindi mo madedegrade si CAMP. And higher levels of CAMP will cause higher contractility. Okay? So those are your inotropes. Other drugs that can be used for your heart failure are the following. Siyempre, you have your vasodilators, no? Na na-discuss na rin earlier, no? You have your diuretics, particularly furosemide and spironolactone. So the following drugs actually can be given to decrease the blood volume, no? Minsan ginagamit sila together, no? Yung spironolactone and furosemide. Kasi remember, your spironolactone can hold, no? It's a potassium sparing diuretic kasi it can hold in the body yung potassium natin. Pwede siyang mag-hyperkalemia. While your furosemide, it throws away your potassium. Hence, mixing them together, no, yung spironolactone and your furosemide can, okay, parang equilibrate yung levels of potassium in the body. So pwede silang gamitin together, no? And at an isokalemic dose, no? Next is your beta blocker naman, no? One thing that you have to remember for your beta blockade, no, is that hindi sila pwede for acute heart failure or yung mga acutely decompensated na heart failure natin. Okay? And lastly, your angiotensin and antagonist, it's the first line for your chronic heart failure, no? Kasi makikita natin dito, okay, later na to, no, yung sacubitril valsartan, no? Makikita natin na ang cornerstone in improving the heart failure survival are the following, no? Yung A, B, A, okay? And tong SGLT2. A for ACE inhibitors, no, yung or anything that inhibits your RAAS system, no, kasi syempre bababa yung blood pressure doon, no, it can help in the total blood pressure control and heart failure control then as well, no. While your beta blockers prevent you increased demand, no, aldosterone antagonists in the form of your spironolactone, no, or eplerenone, pwede din, but spironolactone is mas madalas gamitin sa clinics, and your SGLT2 inhibitors. Saan nyo maririnig yung SGLT2 inhibitors? Sa mga patients with diabetes, no? Hindi siya actually, yung use niya talaga dito is for controlling yung blood volume, no? Kasi it can also decrease the level of your sodium. Hence, ang mangyayari would be it can pull out the water as well, no? Which can improve the control of blood volume in the body. So those are the additional heart failure drug, a cornerstone in the heart failure management, no? Particularly sa mga patients with reduced ejection fraction, yung mababa yung contractility nung or ejection fraction nung heart itself. Okay? So and balikan lang natin yung neprilysin inhibitor, no? You have your sacubitril valsartan. Maganda siyang combination na ginagamit ngayon for heart failure. However, medyo mamahalin siya, no? Kaya hindi siya masustain for some patients. Okay. Next would be our cardiovascular drugs, no? For your sorry po ulit. Okay, next will be our antiarrhythmic drugs, no? So our antiarrhythmic drugs can be divided into 4. Your class 1, your class 2, class 3, and class 4. Your class 1, these are your sodium channel blockers. While your class 2, they are your beta blockers. So ito sodium channel blocker. Beta blockers. Your class 3 is your potassium channel blocker. And class 4 are your calcium channel blockers. Okay. For class 1, no? So class 1 muna tayo. Meron siyang tatlong types. You have your class 1A, class 1B, and class 1C, no? Your class 1A, what it does is it prolongs, no? Prolongs the action potential. This one, it shortens. Yung class 1C, wala siyang effect dun sa ating action potential. Again, class 1A prolongs. Class 1B, it shortens the action potential. And class 1C, okay, it has no effect on the potentiation. So these are the following drugs that you have to remember under this class, no? Dati madami sila mga mnemonics for this one, no? Pero ako kasi I do it differently, no? Kasi nalilito ako dun sa letter lang, like double quarter pounder. Hindi ko siya ma-recall kung propafenone ba siya, propafenone ba siya or procainamide kasi parang silang letter P or phenytoin, no? So what I did was to create a different one, no? So for example, ito, try natin. 1A sounds like IA, di ba? Kasi mukha siyang I, no? I and A. So inaya, no? Aya, IA. Inaya mo si Queen, no? Para kumain sa pyramid. Para kumain sa pyramid. So inaya mo si Queen, no? Queenie din. Para sounds like parakain. Parakain. Okay, parakain na maid, no? Sa pyramid, no? Disopyramid. So disopyramide. So imaginein mo, inaya mo yung queen para kumain kayo sa pyramid. Next would be your class 1B. Your class 1B, di ba? Sounds like IB. Okay, IB. I believe. Okay, I believe. Parang Miss Universe. I believe that talking to Mexi, okay, talking to Mexi, okay, will lead to funny things. Okay, funny things. Okay, so talking sounds like tocainide, no? Tocainide. Mexi is mexilitine. Lead is lidocaine, no? Lidocaine. Funny things sounds like phenytoin. Basta ganun lang siya. Okay, penny things. Okay, phenytoin. Okay, so lidocaine, phenytoin, tocainide, and your mexilitine. Okay, so medyo weird yung mnemonics pero trust me, as in gumagana siya, maalala niyo siya. Okay? And then last would be your class 1C. Your class 1C, no? IC. So it's like IC. Sounds like IC, no? IC, prof. So nakita mo si prof mo, flex pa more. Okay? Nag-flex pa more. Okay? So kung nag-flex siyang ganyan. Okay? So IC, prof, flex pa more. So prof for propafenone, flex for flecainide, more for morizicine. Okay? So these are your class 1 drugs. Again, ano ang class 1 drug? Anong blina-block nila? Your sodium channels. Your sodium channels. Next are the following. Your class 2 drugs, no? Your class 2 drugs, sila yung mga beta blockers natin, no? Marami yan, sila yung mga olol, no? Nag-end sa olol. Your class 3 drugs will be your potassium channel blockers, no? We have your sotalol, no? Sotalol here. Your sotalol is also a beta blocker, but it also has a potassium channel blocking effect, no? It's one of the anong tawag dito? Parang exception, no? Dun sa or parang unique characteristic ng sotalol na added effect niya for it to become a class 3 antiarrhythmic. Okay? Okay, so these are your sotalol. And your class 4, ito yung mga calcium channel blockers natin. Okay, so those are your antiarrhythmic agents. Okay, so next, punta naman tayo sa ating mga diuretics, no? Ang kulit ko sa cardiovascular drugs. So your diuretics will mainly revolve on this picture, no? Yung ating tubules, no? So dito sa part na to, we have your proximal convoluted tubule. Your proximal convoluted tubule, usually dito yung mga anong tawag dito, acetazolamide, no? Diyan din nagfa-function yung ating mga SGLT2 inhibitors. Ito siya. Dito siya. Yan, yung sodium glucose co-transporter natin, no? Siya yung SG, sodium glucose co-transporter. Okay? So dito naman sa loop of Henle, no? Ang main receptors na nandito would be your sodium, potassium, and 2-chloride as discussed earlier. Dito, which is inhibited by your loop diuretics, diba? While in your DCT, okay, distal convoluted tubule, you have your sodium chloride transporter, and it's inhibited by your thiazide diuretics, no? While here, no, you have your sodium channel, no? Particularly, no, yung mga sodium channel transporter inhibitors natin, no? Okay, so to start, no, punta muna tayo sa carbonic anhydrase inhibitors. Your carbonic anhydrase inhibitors, ang ending ng mga to ay mga zolamides, no? Zolamides, no? Acetazolamide, brinzolamide, dorzolamide, mga ganyan, no? It's used for the treatment of your glaucoma and mountain sickness. And the side effect would be metabolic acidosis. Ano ba ang baseline mechanism of action ng carbonic anhydrase inhibitor? So kunwari, ito yung wiwi. Yan. Tubule mo, no? Ay, ang tawag doon? Yung lumen ng urinary tract mo, itong yellow. This one is the blood vessel. Okay? So dun sa urine natin, syempre may bicarbonate dyan, no? Meron din sodium dyan. So what you want to do is yung sodium hindi rin siya ma-reabsorb, and at the same time hindi rin ma-reabsorb si bicarbonate. So kasi yung bicarbonate mo, no? Dito, nagsisecrete ka kasi din ng H+. So itong H+ and your bicarbonate, nagpo-form ka ng carbonic acid, no? This is your carbonic acid, and kailangan mo ng carbonic anhydrase to form your carbon dioxide, okay? Your carbon dioxide and your water, no? Carbon dioxide and your water. Now, your carbon dioxide kasi it's neutral, di ba? Remember Luna? Neutral, uncharged, no? Lipophilic, sila yung na-absorb. So, papasok ngayon si carbon dioxide dito, dun sa cells ng PCT mo, okay? Your proximal convoluted tubule. Now, si CO2, magdi-dissociate din yan to bicarbonate, no? And H+, no? Using your carbonic anhydrase ulit, no? So, si carbonic anhydrase ngayon, si bicarbonate ngayon, ay papasok siya doon sa loob ng katawan natin or dun sa blood, dun sa intravascular space or the systemic circulation natin, kasabay ni sodium, no? Kasabay ni sodium dun sa isang transporter na same sila, okay? Pero si sodium dapat manggaling siya sa wiwi, no? Papasok in exchange for palabas na proton. Okay? So, na-imagine niyo yan. Nagaling din dito, no? Dun sa H+ na nag-dissociate. Okay? Siya rin yung molecule na yun. So, in essence, no? Pag blinok mo ngayon si carbonic anhydrase, mabla-block yung entry ni bicarbonate, no? Hindi siya makakapasok sa loob. Hence, bababa si bicarbonate sa body, di ba? Magkakos ng acidosis, kaya nagkakaroon ka ng metabolic acidosis. And at the same time, si sodium hindi makakapasok kasi walang lumalabas na H+. Di ba? Walang lumalabas na H+. Nagsistay lang siya dito. Hence will cause further diuresis. Nagigets ba? So that's how your carbonic anhydrase inhibitor works, no? Next would be your loop diuretics naman. As discussed earlier, no, dun siya sa thick ascending loop of Henle, no? And ang main receptor na inhibit niya would be your sodium potassium 2 chloride transporter. And the side effect of this one is your hyperglue as discussed, no? The recall nga natin ano ibig sabihin ng glue? G for glycemia, L for lipidemia, U for uricemia. Sino naman yung may side effect na hypergluc? It's your thiazide diuretic, no? Which acts on where? Sa distal convoluted tubule natin. Okay? C for, what is C? Your hypercalcemia, no? Na ginagamit siya to also treat for idiopathic nephrocalcinosis. Okay? So, ayan, yung ating mga loop diuretics, you have to remember no that they can also cause ototoxicity, and giving loop together with your aminoglycosides can also cause no further irreversible damage to the vestibular system natin. Okay? So those are your loop and your thiazide diuretics. Next, we have your potassium sparing diuretic. Your potassium sparing diuretic is parang governed talaga. Is parang ang mnemonic natin dyan will be SEAT, no? SEAT, S-E-A-T. Yung S-E, sulat nyo siyang ganyan, and yung A-T, ganyan, no? Draw a line in between. Because your S-E and your, yung S-E natin would be your spironolactone, no? Spironolactone, and your eplerenone. Okay? Eplerenone. Yung spironolactone and eplerenone natin, okay? These are your aldosterone antagonists, no? Aldosterone antagonist. Now, normally yung aldosterone kasi it will cause insertion ng ating parang channel doon sa collecting duct, reabsorbing ngayon more sodium, no? In exchange, parang ito, kunwari itong collecting duct, no? It will reabsorb more sodium and excrete potassium, no? Excrete potassium para, okay, tumaas yung blood volume mo. So increase sodium reabsorption to increase the blood volume to increase the blood pressure, no? Kasi magi-increase yung cardiac output mo doon, eh. Yun yung normal RAAS system, 'di ba? Remember, the main controller of your BP would be your RAAS, 'di ba? So kapag na-activate mo up until dun sa aldosterone, ang gagawin ng body, increase sodium reabsorption, magtatapon siya ng sodium ay ng potassium, no? Para tumaas si blood volume mo. But your aldosterone antagonist blocks this one. Si sodium magsistay sa urine, si potassium magsistay sa katawan. Kaya siya tinawag na potassium sparing. Pero at the same time, pinapaihi ka niya. Okay? Pinapaihi ka niya. Kasi yung sodium mo ay mag-attract ng more water. Okay? So that's your aldosterone antagonist na potassium sparing. Next, we have your AT, no? You have your amiloride, no? Amiloride and your triamterene. Okay, amiloride and triamterene. Itong dalawang to, ang ginagawa nila is to block the sodium channel, no? Na makikita sa epithelial sodium channel, no? Na makikita sa collecting duct. Okay? So kaya ko sabi kanina, no, as you go along, pababa yung mga electrolytes na binablock mo, no? Sa tubule, ano nga ulit 'yon? Sodium, potassium 2 chloride. Sa distal convoluted tubule, you block your sodium chloride. Pagdating mo sa collecting duct, your sodium channel blocker na 'yon. Okay? Next, you have your osmotic diuretics, no, in the form of your mannitol. No? Remember, yung osmosis is governed by how many solutes are there on a certain side of membrane. So for example, ito yung blood tubule mo, no? If you have lots of mannitol there, no? It will attract more water, no? It will attract more water to come into the tubule, hence causing diuresis, no? Ang ginagamit rin ng mannitol actually with the same principle, no, in patients with increased intracranial pressure, no, para mas bumaba yung amount of fluid doon sa brain natin, no, especially if nagiging edematous. Okay, next punta naman tayo sa ating dyslipidemia, no? Yung dyslipidemia, syempre it involves yung derangement in the levels of your cholesterol in the body, and what we want to do is to be able to control that through different or several mechanisms, no? For example, your statins, no? Your statins Okay? It's mainly used for hypercholesterolemia, no? And your statin inhibits yung main rate limiting step in your um lipid formation, di ba? Your HMG-CoA reductase, no? It's an inhibitor of that enzyme and it's mainly used for hypercholesterolemia. Pero one of the side effects yan is rhabdomyolysis or myopathy, medyo masakit or makirot yung mga muscles, no? And it's primarily given at bedtime. Bakit? Kasi sa gabi, na-produce ng body yung natural na cholesterol, no? Na ginagawa ng katawan natin, no? Your statins involve, example ng mga yan, yung mga atorvastatin, rosuvastatin, no? Simvastatin, okay? And one of the examples na high-intensity statins natin are your Ator 40, 80, and your rosuvastatin 2040. Okay? Ginagamit yung mga yon for patients na may previous stroke, for example, to prevent yung further repetition of that event. Okay? Next, we have your bile acid binding resins. Your bile acid binding resins, your cholesevalam, cholestipol, cholestyramine, yung mga ganyan. Okay? Ang ginagawa niyan, it prevents the reabsorption of your bile acids. Kasi remember in the intestine, no, pagka na-secrete yung bile natin from the di ba, nasa-synthesize siya sa liver, nasa-store siya sa gallbladder, nasa-secrete siya sa duodenum, no? Pag na-secrete siya doon, no, ang nangyayari, no, it will emulsify yung mga fats na kinain natin, no? Pero once it helps in emulsifying, parang siyang detergent, no? Yung taba pag naghuhugas kayo ng plato, di ba? Kayang parang tunawin nung detergent yung taba, yung mga sebo-sebo, no? Parang ganun yung bile, no? Pero once nagamit na niya for dissolving or emulsifying the fats, no? Ang nangyayari ay nare-reabsorb ulit siya sa body, no? Para reuse siya in the formation of furthermore bile, no? Pero ngayon, ang ating bile acid binding resin, i-inhibit niya yung reabsorption ng bile. So kaya ang nangyayari ay hindi ka makakapag emulsify ng fats na kinain mo, no? Causing a fatty pupu, no, in the form of your then that's what you call your steatorrhea. And hence dahil ganun, no, hindi ka makakapag-reabsorb ng fat, no, dun sa body dahil hindi mo siya na-emulsify dahil wala kang bile acid binding resin, nagkakaroon din ng malabsorption of your vitamin K, which is a fatty it's a fat soluble vitamin, no, kasi hindi ma-absorb yung fat sa katawan. Next, we also have your ezetimibe. No? It's an NPC1L1 transporter inhibitor. No? Ang goal niyan is to prevent the absorption of your cholesterol. And your niacin is an example of a drug that also increases your HDL. And one of the side effects of your niacin is to increase, it can cause flushing, pruritus, and hyperuricemia. Yung hyperuricemia, babalik kayo sa biochemistry niyan. Kasi niacinamide, no, one of the important vitamin, no, pwede siyang ma-convert directly furthermore to uric acid, no, kaya nagkakaroon ng hyperuricemia, no. And lastly, your fibrates. The fibrates activate your PPAR alpha. Your PPAR alpha will then increase the synthesis for your lipases, no? And your lipases will then degrade your fatty acids, causing reduction in the in the absorption of your cholesterol. However, your fibrates can precipitate the formation of your gallstones. Alin dito ngayon sa dalawang to ay sa limang ito yung bawal pagsabayin, no? You have your statins and your fibrates. Your statins and your fibrates can increase, no, the precipitation of your rhabdomyolysis or your myopathies as well. Okay? So yung dalawang yan ay bawal pagsabayin. Okay? I think for that, no, daanan ninyo pabalik, no? May hinanda kami sa inyo ng mga section synthesis, no? Please try to answer those at this point, no? Ito yung time na you pause the video, you go back to the handout, and then you fill out all these section synthesis questions para at least mag-guide kayo, no? Kung ano yung mga napagdaanan nating mga topics. So that's all for our cardiovascular drugs. Okay? Thank you. So rest muna and then I'll open the next video once you're ready. Okay? Huwag masyadong magtagal ng rest. Okay, bye-bye. Okay, so welcome to our next topic, no, in pharmacology. We have the drugs acting on the smooth muscles, no? Yung mga drugs acting on smooth muscles minsan mediated sila ng mga different receptors such as the histamine receptors, yung mga serotonin receptors, and your prostaglandins as well, no? So, isa-isahin natin sila. Simulan natin with your serotonergic drugs, no? For the serotonergic agents, ang goal talaga natin dito is for us to be able to classify kung anong type of serotonin receptor siya, anong drug ang nag-act dun sa receptor na yon, at para saan siya. Actually, mainly umiikot dun yung mga questions, no? So, simulan natin. 5-HT1A partial agonist, no? Example nito ay buspirone, no? Yung buspirone, ginagamit siya for anxiety disorders, no? And this will be further discussed by Gabby soon in the next coming topics, no? Your CNS topics, okay? Next, we have 5-HT1D. 1D. Sounds like one direction, di ba? You'll have a trip to, tagasan ba mga 1D? Sa UK, di ba? You'll have a trip to UK. Pagdating mo sa UK ay biglang sumakit-sakit yung ulo mo, no? Para maalala ninyo na triptans, no? Your triptans are involved in the treatment of your migraines. No? They are 5-HT1D agonists. Okay? Kung mapapansin nyo, no? Usually agonist sila lahat. No? The rest ay may isa lang na antagonist, no? At dalawang partial agonist. Okay? So, next, 5-HT2A. Yung 5-HT2A naman, we have your ergot compounds. Your ergot compounds includes your ergotamine and ergonovine. Your ergotamine dyan, ginagamit din siya for migraine. Similar to your mga triptans. So while your ergonovine, it can be used for postpartum bleeding, no? Postpartum bleeding disorders, no? Kapag katapos mga anak pero tuloy-tuloy pa rin yung dugo, no? You can give that. But you can also give yung mga oxytocin natin for that, no? Para mas mag-contract yung uterine muscle natin. Okay, after birth. Okay. Next, we have your 5-HT3 antagonist, no? Again, sabi ko yan lang yung nag-iisang antagonist dyan. These are your cetrons, no? Ondansetron, palonosetron, mga ganyan. Okay? Cetrons, no? Isulat niyo siya pa ganito. Cetrons. Okay? For you to remember that 5-HT3 inhibitor, antagonist, will be your cetrons. Okay? Sila ay ginagamit for post-operative nausea and vomiting or post-chemotherapy nausea and vomiting. Okay? So, next, 5-HT4 partial agonist, we have your tegaserod. Your tegaserod, ginagamit siya for IBS, irritable bowel syndrome, and your constipation. Okay? Pwede siyang gamitin doon. So, those are the serotonergic agents natin. So, ayan. So, triptans, nabanggit kanina, they can be used for migraine. Example, sumatriptan. So, recall, cetrons, di ba? 3, no? 3 for cetrons, chemo and post-operative nausea and vomiting. Tegaserod increases intestinal motility, no? Ginagamit for IBS and constipation. Okay, next, we have the ergot alkaloids. Nabanggit na to kanina. Ergotamine is for migraine, no? It can cause retroperitoneal fibrosis. While your antagonist, we have your ergonovine, no? Novine, no? Novine, parang novena, na parang nagdadasal ka na wag nang dumugo yung matres, no? Parang imaginein mo ikaw yung asawa or partner, for example, no? Dasal-dasal ka dyan na wag nang mag-bleed or mag-postpartum bleed. Ganun ko siya na-recall, no? Novine or gonovine, so antagonist. Okay? So next, we have your histaminergic drugs. Okay, for your histamine, so particularly mga antagonists natin, no? We have your H1 antagonist and your H2 antagonist. Your H1 antagonist, mas ginagamit yan para saan? Sa mga allergic reactions natin, no? We have later on discuss natin sila, no? Ito sila, no? First generation ay ang diphenhydramine natin, no, ginagamit siya usually for yung mga allergic reactions. If you want a more strong or potent drug for yung mga urticaria, yung mga hypersensitivity reaction, you can give diphenhydramine. Now, next dyan, yung mga brompheniramine natin and chlorpheniramine, makikita niyo yan actually sa mga cold medications natin, no? Kung pansinin niyo, nung bata ako lagi kong pinapansin yan. So sa Neozep, mga ganyan, napapansin ko siya chlorpheniramine, meron pa nga phenylpropanolamine. Although it's not an antihistamine, no? So ayan, so yan yung mga nasa cold medications natin. And then your cyproheptadine is also a type of ang tawag dito, antihistamine, pero it can be used for serotonin. It can be used for serotonin syndrome. Okay? And lastly, pinakilala dyan sa mga cyclizines natin ay si meclizine and buclizine. No? Ginagamit sila for nausea and vomiting. May kita niyo yan saan? Sa, ano yun? Yung para sa hilo. Bonamine, no? Bonamine, yung meclizine natin. Okay? Dati biyahilo din ako. Mahilig ako sa meclizine. Pero ngayon, I think na-overcome ko naman siya habang tumatanda. Okay. Next, your second generation. Yung mga second generation natin dito, mga lesser sedating, they do not cross the blood-brain barrier kasi. Remember that your first generation kasi they also have anticholinergic effect. Okay? Kaya sila merong CNS effect, no? Pero yung second generation natin, they do not cross the BBB and they are lesser sedating. So now we're done with H1 antagonist. Punta tayo sa H2 antagonist. Yung histamine 2 natin, may kita yan sa ating stomach. No? Pag inantagonize mo ang H2, it will decrease the level of your acid secretion. No? Acid secretion. Hence, it is used for peptic ulcer disease, yung mga GERD, and however, it can cause gynecomastia, no? Your gynecomastia, particularly your cimetidine. Okay? So that's all for your histamine antagonist drugs, no? Next, punta tayo sa prostaglandins. Okay? So prostaglandins parang ano to, drugs for serotonin na acting on the serotonin receptors. Ang goal talaga natin dito, alam natin kung anong analog siya, okay? Anong analog siya at ano yung use niya, okay? So for E1, may dalawang E1 dyan, no? Your alprostadil and your misoprostol. Your alprostadil, ginagamit siya for erectile dysfunction, no? Erectile dysfunction and to help, no? Open lang yung ating ductus arteriosus, no? Ductus arteriosus. Kasi you want it to be open before certain surgery happens, no, in the young. Okay? You want it patent and open. Pero ano yung gagamitin mo pag gusto mo na siyang i-close? You give your indomethacin, yung mga NSAIDs natin. Because remember, your NSAIDs are antagonists of your prostaglandin. Ganun yun na lang siya isipin, no? Alprostadil, no? Agonist siya ng analog siya ng PGE1. Hence, it causes the patency of your ductus arteriosus. Okay? So, misoprostol naman, ginagamit siya for NSAID-induced gastritis, no? Kasi your prostaglandins, di ba? Remember, in the stomach, no? Ang protectant, ang nag-i-increase ng protection, no? From the acidic contents of your stomach ay prostaglandin, no? Increased prostaglandin parang it will increase the protective barrier, no, pag mas madami kang prostaglandin. So hence your misoprostol, no, pag ginamit mo siya, it's used for your NSAID-induced gastritis. Okay. Next, your latanoprost. Latanoprost is a PGF2 alpha, no? PGF2 alpha analog, no? Ang palatandaan ko dito, no, it's used for chronic glaucoma, no? Chronic glaucoma. And kailangan, di ba, eyesight, no, yung affected pag may glaucoma ka. You want to see, no, your FAFA. Okay, FAFA. So kailangan wala kang glaucoma, no? You want to see your FAFA, so latanoprost, glaucoma. Okay? Next, dinoprost. Dinoprost is a PGE2, no? E2 analog. It's used for cervical ripening, no? Para mas ma-induce mo yung labor, no? Mas ma-expel or ma-deliver si baby doon sa puwerta, no? So your dinoprost, ang palatandaan ko dyan ay, okay, kunwari nanganganak na yung nanay, no? Nanganganak siya ganyan, palabas na yung baby. Tapos, paglabas ng baby, nakita mo, oh, ito, tignan mo to. Tignan mo ito, okay? Paglabas ng baby, bakit mo titignan? Mukha siyang naging dinosaur pala yung pinanganak niya, no? So, ganun pala siya na-recall. So, Dinoprost, no? Ito, okay? Kasi nanganak siya ng dinosaur, okay? So, next, we also have your Carboprost. Your Carboprost, no? It's also used for postpartum hemorrhage, no? It's similar to your Latanoprost, no? Which is a PGF2 alpha, no? But it's more used for your postpartum hemorrhage rather than for the chronic glaucoma. And lastly, your Epoprostenol, which is a PGI2 analog. It's used for pulmonary hypertension. Okay. Next, for the smooth muscles naman, another drug for under your smooth muscle ay yung drug na ginagamit for asthma and your COPD. No, your the lining of your yung respiratory system is mainly lined by your smooth muscles, no? Kaya kapag nagbigay ka ng mga bronchodilators mo, such as your SABA and your LABA, mas nakakontrol mo, no? Yung action nung mga ano tawag dito, muscle doon kasi it's mainly covered with smooth muscle, no? So you have your SABAs, no? It's used for it's a drug of choice for your acute attacks, no? Yung example ng mga yan, yung mga salbutamol, terbutaline, no? However, no, if we recall, no, dun sa latest na GINA guidelines natin, no, ginagamit na mas indicated na yung formoterol plus ICS for even acute attacks. Kasi yung salbutamol, no, hindi na siya ganun ka-recommended for that, no? So we shifted na to formoterol. Formoterol is really a long-acting bronchodilator, no? It falls under your LABA. However, no, we have to remember that it also has a fast onset, no? Agad-agad yung onset niya. Kaya nagkakaroon din siya ng effect for acute attacks, no? Okay. So, we also use your muscarinic antagonist, no, as a reliever kasi 'di ba if you recall, no, yung if you inhibit your muscarinic receptors, particularly yung tropium compounds natin, yung mga family ni atropine, di ba? Atropine, if you remember, dry as a hair, di ba, mga ganon. So it decreases the secretion. It also causes bronchodilation, no? Hence, nakakatulong yung ating muscarinic antagonist in relieving, no, the acute attacks in asthma and particularly COPD. Okay, mas ginagamit siya for COPD. So itong mga to, no, muscarinic antagonist, mas binababaan nila yung parang inflammation, I mean yung tawag dito, the increased secretion or fluid doon sa ating lungs para mas makahinga yung pasyente natin, making them more relieved, no? Next, we have your controllers. Kung kanina na-discuss natin yung mga relievers natin, ngayon yung controllers natin. Main na ginagamit natin as a controller medication in asthma are our corticosteroids. Your corticosteroid includes yung fluticasone, budesonide, no? Pero remember, if yung ating inhaler ay nagko-contain ng corticosteroid, ano yung kailangan mong sabihin sa mga pasyente natin? Kailangan nilang mag-gargle or kailangan nilang maglinis ng bibig, no? I-swish nila with water yung bibig para hindi masuppress yung immune function na nandun sa local area ng bibig natin, no? Dahil dun sa mga corticosteroids, no? And that will cause kasi candidiasis, no? Magkakaroon sila ng oral thrush. Okay, next na controller will be our leukotriene synthesis inhibitors. Example nito ay yung Zileuton, no? It inhibits your 5-lipoxygenase, no? And when you inhibit your 5-lipoxygenase, if you recall, di ba dun sa COX and LOX pathway natin, di ba COX and LOX pathway natin, di ba nanggaling yan sa arachidonic acid, no? If you di ba dun sa LOX pathway, dun na-form yung leukotriene. Yung leukotriene, it's a potent bronchoconstrictor, di ba? So, pero pag in-inhibit mo ngayon si LOX, wala kang leukotriene, wala kang bronchoconstriction. So, hence, that's how it works, no? Yung Zileuton natin. Next, syempre, kung si leukotriene na-form siya, pwede mong inhibit ngayon yung pagdikit niya dun sa receptor. So, what do you give for that? it's your Lucas, no? Yung mga Monte Lucas, Zafir Lucas, no? And ang use nun inhibits the binding of leukotriene to the receptor, hence preventing yung irritant reaction nung leukotriene into the lungs. Okay? And one of the side effect of your Montelukast ay yung Churg-Strauss, no? Churg-Strauss syndrome. Okay? So one more thing, we have your mast cell stabilizer. You have your chromalin sodium. Yung mast cell stabilizer natin, ginagamit lang sila for prophylaxis. Kasi remember that your mast cells, no? Your mast cells in the body, it contains a lot of histamine. So ang ginagawa ng mast cell stabilizer is stabilize niya yung membrane ng ating mast cells para kapag nagka-anaphylactic or allergic reaction ka, hindi ma-degranulate, no? Hindi mag-degranulate yung cell, yung mast cell natin. Hence, hindi lalabas si histamine, hindi magkakaroon ng allergic reactions na related to the histamine excess in the body. Okay? So, I think that's it for our drugs for the smooth muscles, no? Ayan, the very direct and ano lang siya, sobrang direct to the point lang, no? Madali lang siyang intindihin. But you have to remember kung ano yung mga receptors, ano yung mga indications for them. Okay? So I'll see you. Actually, the next topic will be Gabby, if I'm not mistaken, no? Gabby will take over the next few topics. And magkikita ulit tayo pagdating ng antibacterials. Okay? I'll see you guys, no, in the next round. No? Okay, good luck. Bye-bye.